is anyone sharing the PPT or should I share?
If you want, I can do the.
I'll do the sharing, sir.
Okay,
I'm
fine.
ready.
Excuse me, doctor. We are live now.
No, I can share. Okay, fine. Okay.
Niranjan,
A
over to
very
you.
good evening to all those who have joined us for day 2 of this epic edition of Naadi 3.0 International. So, with no shortage of the enthusiasm, we are here in day 2 and we have a star-studded lineup of cases. And today our theme is going to be posterior segment. So, let me quickly share my screen and we can get going. So, for all those who are joining us for the first time today, so our idea of this Noinadi case competition culminated from this very Tirukkural. Noinadi, Noi Mudal Nadi, Adathanikkum, Vainadi, Vaipachayal, which basically means diagnose the illness, trace its cause, seek the proper remedy, and apply it with skill. So, with that, we went ahead and initiated this project, Noinadi, which happened for the first time a couple of years back under the leadership of our immediate past president and the governing council at that point of time, Dr. Sonal Kalia ma'am, and the entire governing council. And we four, headed by the brainchild of Dr. Karthikeyan sir, we four came together to organize this. And to grace the occasion, we had the then president-elect of TNOA, Dr. Nirmal Frederick sir. So then we went on with season 2, and we had a very similar arrangement with 3 prelim sessions. And here we are at season 3, where we have gone international, and we've had the representation of over 15 countries from across the globe. And we are greatly indebted to each and every single one of them for joining us in this program. So with no further ado, it is my immense pleasure to welcome the judges for today, the stalwarts in the field of vitreoretina, who will be judging the presentations and the cases that are being presented. So first up, we have the privilege of having with us Dr. Shreyas Temkar, who is the assistant professor at vitreoretina and uvea Department of Ophthalmology at the prestigious JIPMER, Puducherry. Sir has done his training from Bangalore Medical College and the coveted RP Center AIMS, and has done a senior residency from there as well. He has several other accolades to his name and published over 72 index publications and has received several awards. Next up, we have Dr. Ashish Markan, who is currently the assistant professor at RP Center, AIMS, New Delhi. And he is one of our very own executive members at YOSI. And he has several qualifications, including MD from AIMS, MCH from PGI, and FRCS, FICO, and many more. And he is also the managing editor of DOS Times and executive member of YOSI, as I had mentioned. And he has several achievements and awards to his name. Thank you, Dr. Ashish, for joining us, and Dr. Shreyas sir for joining us. Then we have Dr. Nawazi Sheikh. She has been a very integral part of many of our YOSI programs in the past. And she's completed her MBBS from Government Medical College, Miraj, Maharashtra, and her MD from, again, the prestigious RP Center. She's currently working as the consultant ophthalmologist, and she is working as consultant ophthalmologist for empowering national healthcare programs with artificial intelligence by Ministry of Education, and was awarded the best junior and senior resident awards during residency at RPC. And she has more than 30 PubMed indexed articles.
Yeah.
And
Dr. Nawashis became assistant professor at present. This is a old CV. Yeah.
oh, okay.
I think Dr. Pranesh can take over and introduce the panels.
Yes, I invite Dr. Pranesh sir to introduce the panelists for today.
Thank you very much, Niranjan. Thank you, Karthik, for the shift over. So for the panel, we have a very dynamic young people. To start with, we have Dr. Anujit Paul, who's a consultant cataract and vitreoretina surgeon at BBI Hospital, Kolkata. He's an assistant professor for Ramakrishna Mission and an visiting consultant in a few hospitals. Fellowship of Vitreoretina in BBI Hospital. He's a recipient of IGO Platinum Award, TNI Gold Medal, Ranjan Ray Young Ophthalmologist Award, and he has several posts and publications to his name. Ranjan, can you? Yes. And then we have the ever dynamic Dr. Mohammad Azam. He's done a fellowship in Vitraratna from IGMH Government Hospital in Maldives, the founding member and the president of Maldives Ophthalmic Society, and the council member of South Asian Academy of Ophthalmology. He's a young ophthalmologist leader and a past ex community member of Maldives Medical Association. And then we have the lady power. To add in the lady power, we have Dr. Isha Acharya, who's completed MBBS and Masters from UCMS and Guru Tej Bahadur Hospital in Delhi, and Vitraratna Fellowship from Narayanathala, Bangalore. 25 publications, numerous papers and posters to her, poster accolades to her name, and she's a reviewer of European Journal of Ophthalmology. And she has got the Best Poster International Hero, Best Paper, and a runner-up in Ophthalmic Images at IIRSI to her name. And myself, Dr. Pranesh Ravi, I'm a moderator of the session.
Let me take the privilege of introducing you. So, Pranesh sir is a very integral part of the team Naadi organizing team, and he is a cornea and phaco-refractive consultant, and currently working as a phaco-refractive and a corneal surgeon at the Eye Foundation Group of Hospital, Pollachi, and now I think he's moved on to Hosur. Am I right,
Yes.
sir?
Yes, yes.
Yes, heading the department there. And he has several publications to his name, has authored 4 book chapters, and is really a tech giant in our YOSI team. Thank you, sir, for being there with us. And this is myself requesting Pranesh sir to just make it brief so that we can start it off.
Yeah, so Niranjan is a great guy. He's the best outgoing student of RIO, one of the brightest product of Regional Institute of Ophthalmology in Chennai, and he's very knowledgeable, and he's got the Midas touch. Whatever he touches turns gold. So a great guy and great knowledge to have in our team. Great leader also. So he's taken on so much of initiatives, and so proud to see him do so much in such an young age.
Thank you, sir.
Perfect.
And we have other co-organizers, Dr. Sameer Chaudhary. And with that, we come to the end of the initiation of the program. And just a second. Karthik sir, can we straight away start with the first presenter?
Yeah, we can
It's
start with
Dr.
the
Gulnoor. Dr. Gulnoor, you can share your
So I
presentations, Doctor.
invite Dr. Gulnoor to come forward and share her presentation, and I'll be keeping the timer. Over to you, Dr. Gulnoor.
Manjula ma'am, sorry Niranjan. Manjula ma'am, can you help with the timer?
Yes, doctor.
Yeah. Niranjan
Yes, sir.
ma'am,
She has given me the control, so I'm all set and ready, sir.
So you have to keep visible to all the timer. I am not
Yes,
able
sir.
to
Yes,
see.
sir. Show timer to all is switched on, sir.
Hello, everyone. My name is Gulnur Abdullayev Mammadova, and I'm joining you today from Azerbaijan. Greetings from Azerbaijan. It's my pleasure to be a part of this webinar, and I'm going to talk about cytomegalovirus retinitis in a HIV positive patient with bilateral involvement. It's a case report. I hope you will find the presentation useful and interesting. So, our patient is 34 years old female. She was referred to our clinic on 14th of July due to progressive bilateral visual loss over 1 week. And she disclosed that she's an HIV positive patient. At initial examination, a visual acuity for right eye was light perception, for left eye also was light perception. On the fundus examination, we saw a white retinal patch with hemorrhages along the vessels and minimal vitreous inflammation. This is a fundus photo of the right eye, and this one is for the left eye. We've done OCT, and OCT showed us a thickened hyperreflective retina with disrupted layers and signs of necrosis and edema. So this one is fluorescent angiography photos for the right eye. You see, and this one for the left eye. After all, after all examinations, the patient was referred to an infectious disease specialist for further evaluation. After a clinical evaluation and relevant laboratory testing, we revealed that the patient is CMV IgG positive, and this is confirming CMV retinitis in the setting of AIDC. After all examinations, laboratory tests, and clinical analysis were completed, we prescribed the following treatment for the patient. Firstly, we start from ganciclovir 5 intravenosus, 5 milligram per kilogram every 12 hours for 21 days. At the next checkup, the patient's vision had improved in the both eyes. For right eye hand motion, left eye the same hand motion. We continued treatment with ganciclovir. So at the next checkup, the visual acuity already was 0.01, is eccentric for the both eyes. After we switched our treatment to oral ganciclovir daily, 900 milligram daily, and the visual acuity at the examination also was for both eyes 0.01. So at the last examination, we saw that visual acuity was hand motion for both eyes. So I want to say that the patient initially responded well to oral ganciclovir therapy with notable visual improvement. But you see my presentation or no?
Yes,
Yes, doctor. Yes, yes.
yes,
Please
yes.
proceed.
Please
Yes,
proceed.
and after switching to one ganciclovir, a gradual visual decline was observed. But unfortunately, our patient subsequently lost to follow-up. So I want to say that this case emphasizes that the need for close monitoring and individualized antiviral management in CMV retinitis, even in the patients with preserved immune function. So CMV retinitis means that ocular emergency in severe immunodeficiency, early detection and progressive treatment, and it means that our vision saved. So in conclusion, I want to say that your vision matters, so take care of it. Thank you so much.
Thank you, Dr. Gulnoor, for those wonderful points and take-home messages. So I invite our judge, Dr. Ashish Markan, to share his inputs on this case.
Yeah, thank you so much for the presentation, Dr. Gulnoor. I just wanted to ask, did you actually check the CD4 counts also for the patient?
Yes, it was about, it's lower than 50.
Okay, so I think a good case to show, but I also felt that there was a component of bilateral CRVO in this patient. And though there was a patches of retinitis, did you also consider starting patient on systemic valganciclovir, or did you just give an injection ganciclovir?
Thank you for the question. Yes, we started from intravenous ganciclovir.
Intravenous.
Yes.
Okay, fine. So I think whenever a patient presents to us with a bilateral presentation of retinitis, I feel it is very important that we just not treat it locally, but should also be given in a systemic way. Either you give IV or oral. Like we preferably give it oral Valgan 900 mg BD induction dose for about 3 weeks, and then we shift on to the maintenance dose. And secondly, it is very important to monitor these patients according to the CD4 count, because once the CD4 count it starts to improve, obviously you have started the therapy, the retinitis lesions will tend to resolve. But sometimes these patients, at the time when the CD4 count starts to improve, they develop this immune recovery uveitis, and probably at that point of time there are these vitreous membranes which form, and they can actually develop a retinal detachment. Like in your case, the patient was lost to follow up, and so I think it is very important to counsel the patient that they have to be very regular with the follow-ups. Otherwise a good case to present. Thank you so much.
Thank you so much.
Thank you, Dr. Ashish, for your valuable inputs. I request our panelist, Dr. Anujit, if he's there with us, to share his 2 points on this. Or Dr. Isha, if you could share your perspectives on this case.
Niranjan,
Hi. Very nicely presented, Dr. Gulnoor. And especially the pictures were quite good. The thing is, as Dr. Ashish Markan sir said, that the CD4 count monitoring is quite important in this particular scenario, especially when it's a bilateral involvement. We are worried about the immune status. And other than that, can you tell me what will be the indication for intravitreal ganciclovir?
As we revealed the patient to infectious disease specialist, that she treated this treatment. That's why we cannot interrupt for her treatment.
Okay. So exactly. So the treatment was rightly done because as it is a bilateral condition and you have given a systemic intravenous therapy. So whenever supposedly it's a unilateral condition and it's more of a zone 1 involving site-threatening condition, we can also consider intravitreal injections in such patients. So very good case. Congratulations.
Thank you so
Thank
much.
you so much. Thank you, Dr. Isha. Moving on to our next presenter, Dr. Nahal Mustaq Khan from Bangladesh. Dr. Nahal, Dr. Gulnoor, if you could please stop screen sharing. Thank you. Dr. Nahal? Okay, I think he's yet to join us. Then we have, we'll move on to the next one. Next, we have Dr. Anisak from Indonesia. Dr. Anisak Fitriana? Yes.
Yeah. Good. Doctors. So,
yes, please.
yeah,
please,
may I share the screen of my presentation?
Yes, please.
Okay.
Please go ahead.
Yeah. Is it clear? Can you see
Yes.
my presentation?
Yes.
All right. Okay. So, yeah. Wait a second.
Dr. Anisak, just
Yeah.
take your mouse cursor, click inside the slides and use your arrow mark, the right-hand side arrow mark to move.
Yeah.
Try that one.
Yes.
Working?
Yeah. Oh, wait a second.
Perfect.
Okay.
We'll
Yeah.
start. Yeah. Manjula ma'am, can we start the timer?
Yes, sir. I'm looking into it, sir. We'll do that.
Perfect.
Yes, Dr. Anisak, you can start.
All right. Thank you, doctor. So good day and good evening, esteemed judges and also colleagues. It is an honor to have the opportunity to present today, joining all the way from Indonesia. My name is Dr. Anissa Fitriana from Netra Eye Clinic, Bandung, Indonesia, and I'll be sharing a case demonstrating complete resolutions of recurrent pseudophagtic cystoid macular edema after nepafenac 0.3% monotherapy. So let me begin with a brief introductions. As we know that pseudophagtic cystoid macular edema is a common cause of visual decline after uneventful cataract surgery. And while intravitreal steroids are effective, their use is limited by the risk of glaucoma and also endophthalmitis. Recurrence may also occur once the steroid effect diminishes due to the persistent inflammatory pathway, which presenting a therapeutic challenge. So topical NSAIDs is commonly used as a prophylaxis to prevent the PCME after cataract surgery. But how about it used for the treatment of PCME, especially for the recurrent and also unresponsive steroid therapy cases? So this case will illustrate how a topical NSAID can restore both structure and also visual functions of the patient. As for the case illustrations, a 64-year-old female presented with a blurred visions 1 month after a uncomplicated cataract surgery. Her presenting UZVA was 0.1 using Snellen chart, and also OCT revealed kystic and intraretinal and also subretinal fluid consistent with PCME as shown in the picture. She then received intravitreal triamcinolone, in which her vision was improved to 0.63 and OCT showed complete resolutions. But however, 2 months later, she come back and her vision was dropped into 0.05 with recurrent kystic intraretinal and also subretinal fluid. Rather than repeating intravitreal injections, we opted for a non-invasive approach using topical nepafenac 0.3%. And after 1 month of treatment, the patient's vision recovered to 0.8 and the OCT demonstrate a normal foveal contour, which complete resolutions of both intraretinal and also subretinal fluid, as seen in the picture. So this schematic summarizes the pathogenesis of the PCME. So we know that surgical trauma will triggers the release of COX-1 and also COX-2 that will later convert the arachnoid acid into prostaglandin that will accumulate in this anterior chamber, and later the prostaglandin will increase the vascular permeability, resulting the leakage of the blood retinal barrier and also the development of the cystic spaces within the macula. Nepafenac 0.3% is a potent topical NSAID that acts precisely at this pathway, inhibiting COX-2 that will block the prostaglandin synthesis, while it has high ocular penetrations that allows to reach the posterior segment non-invasively, reducing inflammations and restoring the integrity of the BRB, and also had a longer durations of actions. So the combined structural and also functional recovery observed in this case suggest that high concentrations of nepafenac can restore retinal homeostasis by stabilizing the BRB and also suppressing the residual inflammations proven by the reduce of CST by the macula and also the improvement of the visual acuity of the patient. So for the conclusion, nepafenac 0.3% may serve as a non-invasive, effective alternative in managing recurrent PCME, minimizing the need for repeated intravitreal injections. But further studies, I recognize that needed to validate the long-term efficacy and also recurrent prevention of the use of nepafenac in recurrent PCME. Thank you, Doctor.
Thank you, Dr. Anisak, for your wonderful case presentation. So now I invite our judge, Dr. Shreyas sir, to
I'm
share
here.
his inputs.
Yes. Dr. Anisak, that nicely documented the case of recurrent pseudophakic CME. So I have two questions here. Actually, usually the course of a pseudophakic CME is for spontaneous recovery. So usually topical drops alone suffices in most of the cases. So I have two questions for you. So why was intravitreal triamcinolone selected as first treatment for this patient? And did you notice any risk factors in this particular patient, why the patient particularly developed a recurrence? Usually the pseudophakic CMEs usually don't recur. So did you notice any of the risk factors in these patients like diabetes or anything? So which led to the recurrence of CME?
Okay, thank you, Doctor, for the question. Yeah, I recognize that usually the pseudophakic cystoid macular edema can be restored spontaneously without any medications or treatment, but we consider the triamcinolone since it has a very large and huge SRF and also kystic intraretinal fluid. So the judgment was because the OCT is so high by the CST, and also for the risk factor. Unfortunately, the patient has no history of trauma, steroid medications, and also systemic conditions. So, as for now, we still don't have the judgment why the patient has a recurrent PCME in this case.
So patient was not diabetic.
Yeah, she has no systemic conditions, neither diabetes or hypertension.
Okay, so one of the common causes of occurrence of CME, they say, is abrupt tapering of steroids, which are given post-operatively. So I think that needs to be considered in this particular patient. And again, I think first time also we could have given a try of giving nepafenac eye drops along with increasing topical steroids. And if the patient did not respond, probably we could have gone for IVTA. So this is what I feel. Anyways, nicely documented case. Thank you.
Thank you, Doctor.
Thank you, Shreyas sir, for your inputs. Can we have Dr. Azam sharing his perspectives on this one?
So I think the judge has already asked very important question. And what about the dosage of the drops and what is the duration? Would you like to share it to us?
Yeah, the patient was given a nepafenac 0.3 3% once daily for a month. And I also recognize that the patient has a very short duration of follow-up, and therefore I at the conclusion that we need further and longer follow-up for the patient. So thank you.
And does your post-operative therapy include Nepfenec in regular
No.
basis? It is not.
No,
Okay.
we usually use prednisolone as a topical, and also topical antibiotics for the post-operative at our center.
Okay. Understood. Thank you.
Thank you, Azam sir, for your inputs and questions. We move on to a different country. So now we have a lineup of cases coming all the way from Malaysia. Thank you, Dr. Anisak. If you could please
Thank you,
stop
sir.
screen sharing. Yes, thank you. Thank you so much. Next up, we have Dr. Nurul Afsan Binti Mustafa. So, Dr. Nurul, if you're there with us, yes, we can see your
Yeah.
video. Please go ahead and share your screen.
Am I audible?
Yeah,
Yes,
you're
yes, yes, yes.
Do we have Dr. Nahal here, Niranjan? They are not present, I think. Dr. Nahal?
Yes, sir. Yes, sir. I thought I'll just recall after this one.
Okay, fine. Yeah.
Yes, Dr. Nurul, please go ahead.
Okay. Okay, good evening. Good evening to all the judges,
Your
moderators.
screen is not visible yet, Dr. Nurul.
Ah,
Your screen is not
sorry.
seen still.
Sorry. Sorry, let me.
No, you are yet to share your screen. Could you please share your screen before starting presenting? Screen share your PPT. Yes, yes.
Okay.
Okay. Kindly open your PPT and then we can go ahead.
Can you see my slides?
Yes, yes, Dr. Nurul, please
Okay.
start.
Okay. Hello, good evening to all the judges, moderators, and to everyone. It's an honor to join everyone for presentation this year. So I'm Nurul Afzan binti Mustafa from Malaysia. So today I will present the topic of when beauty blinds. It's a rare case of breast filler injection causing the picture-like retinopathy and paracentral acute middle maculopathy. So we start with the history first. There's 27-year-old gentleman with no medical illness presented to us with both eyes painless, blurry of vision for 2 weeks, and it's been associated with fever, shortness of breath, and lethargy. Otherwise, patient had no ocular complaints and no recent trauma. Patient had been telling us he had history of breast filler injection at unlicensed beauty center, and the onset of symptoms is within 24 hours after the injection. Since then, patient only sought treatment at primary care clinic and was given symptomatic relief. However, patient presented again due to persistent blurry of vision and then was referred to eye clinic. Upon further history, patient has been sexually active with male partners for quite some time. Other history was unremarkable. For ocular examination, visual acuity for both eyes is reduced. No RAPD, anterior segment was unremarkable. And for fundus examination, you can see the multiple retinal hemorrhages and cotton wool spots, mainly in the posterior pole. And that presence of perifoveal retinal whitening also. This fundus photo of both eyes, you can see a lot of retinal hemorrhages, cotton wool spots, and also the perifoveal retinal whitening. Further on, we did the OCT macula for this patient. It's presence of the hyperreflectivity band in the inner nuclear layer, and it's sparing the outer retinal layer. At this point of time, we're thinking what could be the diagnosis. So our first came into our mind is HIV retinopathy, because this patient has high-risk behavior, and also the typical fundus photo. And then we did further test for HIV test, and it's turned out to be negative. And then we're thinking, is it related to breast filler injection? Because the onset of symptoms is exactly within 24 hours after the procedure. After that, we did some reading, and we found that there's one article reported in Sarawak, Malaysia. It's the first ever reported case of puncture-like retinopathy and palm following the breast filler injection. It's happened in 27-year-old lady presented with painless blur of vision for 2 weeks following the breast filler injection. And this is the fundus photo and OCT macula looks like, and it's exactly look like similar to our patients. And we conclude that this patient has puncture-like retinopathy and palm secondary to breast filler injection. So how actually it's happened is when there's incidental entry of filler into the artery that supply the breast, and eventually the particles can travel into the subclavian artery and travel up into the ophthalmic arteries. So and then cause occlusion at the capillary. So tendency for embolic occlusion is higher in distal arteries because of the small lumen, and of course, high volumes of filler injection will increase risk for occlusions. So as for the treatments, we found that no standard evidence-based management for vision loss secondary to filler. However, early detection and intervention may be sight-saving. And then there's one ICODE protocol that's proposed by the group of dermatologists. This one is to treat the retinal artery occlusion after the soft tissue filler injection. What is that is the firstly, they have to call the retinal center immediately. And after that, we have to check the vision and optic nerve function to assess the extent of the damage and do the ocular massage to dislodge the filler embolus and give medication to decrease the IOP to improve the retinal blood flow. And lastly, if we have to reverse the filler using hyaluronidase. This one is using hyaluronic acid. Otherwise, patient can be given systemic steroids to reduce inflammation to improve the retinal blood flow. For our patient, start him on corticosteroid with tapering dose. However, this patient defaulted follow-up and the visual outcome remain unknown. For what we can learn from my case is vision loss from non-facial fillers is rare. However, filler injection nowadays increasing in demand and frequently being performed by non-medical practitioners at unlicensed beauty centers. So this can cause inadvertent entry of fillers into blood vessels, which can cause ocular complications. Therefore, good anatomical knowledge and proper injection technique are very important to prevent the complications. These are my references. That's all. Thank you.
Thank you, Dr. Nurul. Can I invite Dr. Nawashi Sheikh ma'am to share her inputs on this case presentation?
Okay, so this was a very well presented case, and I really congratulate Dr. Nurul for this reporting. I just have one question for you. Since you showed me the ICODE, the protocol for the ICODE, did you do some digital massage or something for this patient?
Okay, this one is actually I did some research after we saw the patient. So eventually, unfortunately, we didn't do any massage.
Okay. So what was the time of presentation from the time of the breast filler injection to the time of their presentation to you?
2 weeks. After 2 weeks.
Okay,
Yeah.
so it might not have actually helped then.
Yeah.
Okay. It's a good presentation. Congratulations. It's a very well reported case.
Thank you.
Thank you, ma'am. So next up from Malaysia, we have Dr. Mohammad Fadil bin Abdul Zain. So I kindly request you, doctor, to share. Yes, perfect. Can we go full screen? I think we are in the middle somewhere. So can we go to the first slide and go full screen, doctor?
Hi. Yeah, can you hear me now?
Yes. Perfect.
All right. Then I'm gonna go here. Okay. Better. Okay. Can you see my slides now?
No, actually they've gone. They were up, visible a bit back.
Is it visible now, my slides?
Not yet.
Not yet. Give me a minute. Share my screen. Okay. Is it visible now?
Yes.
Yeah. Okay.
Yes. We can start.
Okay, good evening, everyone. I am Muhammad Fadil. I am from Malaysia. So I'm going to present a case report on a spontaneous suprachoroidal hemorrhage in a patient which age-related macular degeneration on anticoagulation therapy. As an introduction, suprachoroidal hemorrhage, accumulation of blood in the suprachoroidal space, is commonly occur post-surgery or secondary to trauma. Spontaneous suprachoroidal hemorrhage is extremely rare, particularly in patients with AMD and on anticoagulation. So on literature review, there is a very few reported case on spontaneous suprachoroidal hemorrhage. And then most commonly happen in someone who have hypertension, AMD, and anticoagulation use. Prognosis usually poor with limited visual recovery. The purpose and objective for this presentation is actually to present a rare spontaneous suprachoroidal hemorrhage in a patient with neovascular AMD on anticoagulants, and also to highlight the risk factor, clinical finding, and management approach for the patient. So I'm presenting a case of a 88 years old male with underlying diabetes mellitus, hypertension, and atrial fibrillation, in which he is on long-term anticoagulation, particularly apixaban, for several years. His ocular history includes both eye cataract surgery more than 10 years ago, and also both eye has had done intravitreal anti-VEGF injection last 2 years ago at other hospital. He presented to us with sudden loss of vision of the right eyes for 2 days. It's associated with headache and right eye pain. There's no flashes or floaters, no recent trauma, fall, fever, or cough. On clinical finding, his blood pressure was normal at the time. And then visual acuity of the right eye is actually perception of light. And then the left eye is actually best corrected as 160 due to advanced ARMD. Intraocular pressure of the right eye is 44, and then the left eye is normal. There's this picture showing markedly shallow anterior chamber of the right eye with completely closed drainage angle, and as compared to the left eye with deep chamber and angle is open. Fundus photo of the right eye. This is the best we can get. Actually, show total elevation of retina without retinal break. There's a kissing of retina also noted nasally. Investigation done within BScan, there's a massive near kissing suprachoroidal hemorrhage with minimal vitreous hemorrhage. This patient was started on anti-glaucoma and was consulted to be referred to tertiary center, but he initially refused. So 5 days later, he came back with complaining of severe headache and worsening right ocular pain. IOP had shot up to 50 of the right eye, and then anterior chamber was shallow. Fundus also cannot be seen at this point of time because of the dense vitreous hemorrhage. So the management done to this patient is actually we did give a topical and IOP lowering agents, maximum dose with corticosteroids and acetazolamide, but the patient symptoms was worsening. And then we referred the patient to the tertiary center, and operation was done in which right eye choroidal drainage and anterior chamber washout was done because patient actually developed total hyphema, and we withhold the anticoagulant before the op. Post-operative day 1, the visual acuity of the right eye is no perfection of light, and subconjunctival hemorrhage, total hyphema, IOP is able to reduce to 30. B-scan show vitreous hemorrhage, minimal choroidal detachment superiorly, and the pain was relief over weeks. Then post-operative 2 weeks, we shows there is a reduced resolution of vitreous hemorrhage, and IOP was 30, but patient is actually very comfortable. The discussion part actually, the risk factor of advancing age, AMD, anticoagulation, and hypertension should raise a suspicion of suprachoroidal hemorrhage. The proposed mechanism of injury is subretinal hemorrhage from the CNV extend to the suprachoroidal space. Then the blood accumulation stretches the posterior ciliary artery causing rupture and shear force, thus causing suprachoroidal hemorrhage. Surgical drainage for persistent kissing choroidal hemorrhage after liquefaction is actually one of the management also. So learning point is to identify high-risk patient. Conservative management can be effective if pain is controlled. Visual prognosis is usually poor. As a conclusion, spontaneous ACH is rare, but sight-threatening condition require prompt recognition and multidisciplinary management. That's all from me. Thank you. Yeah, that's all
Yeah.
from me. Yeah.
Yeah, nice presentation.
Mm.
Now we will invite Dr. Shreyas sir for your comments, please.
Yeah, Dr. Fadil, it was a nice presentation of a spontaneous case of suprachoroidal hemorrhage. I have two questions for you. So just like I want to ask you, what is the ideal timing for draining a suprachoroidal hemorrhage? And like, how do you monitor these patients? Like, what investigative modality can you use to monitor the ideal time of drainage, to decide the ideal time of drainage?
From few literatures that I read, some literature say the ideal time is actually 2 weeks from the start of the choroidal hemorrhage. And then yeah, the second question is what, Doctor?
No,
Sorry.
I'm just asking which investigative modality can you use to monitor these patients to decide on the time to intervene?
It's I think it's the B scan, Doctor. Whether it's
Yeah, correct.
worsening or yeah.
Yes, yes. So
Yes.
ideal time they say is 7 to 14 days. So 7
Yeah.
to 10 days, many people say. So not before 7 days because it takes time for the blood to liquefy. And on B scan, actually, you can see the serially follow up the patient and see whether the blood is liquefied, and then you can decide on the drainage timing. So
Yeah.
that's it. Okay. Anyways, nice presentation.
Thank you.
Next, we can call upon Dr. Ariana. Are you available?
Hello,
Dr.
can you
Ariana
hear me?
Binti?
Yeah, hello.
Yes.
Can you hear me?
Yes.
Okay, I will share my slide.
Yes, please.
I request all the participants to stick to 4 minutes time so that you don't get negative marks from the judges.
Can we go full screen, doctor?
Right now.
Yes. You can start.
Wait a minute. Sorry. Hello, good evening, everyone. I'm Dr. Ariana from Hospital Duchess of Kent, Sandakan, Sabah, Malaysia. So today I will present a case about seronegative yet suggestive clinical diagnosis of punctate outer retinal toxoplasmosis, also known as POT. So POT is a typical presentation of ocular toxoplasmosis that affect the outer retinal layer of the macula. So I started with a case presentation. So my patient, 48 years old gentleman, presented with 2 weeks history of left eye central blurring of vision with history of taking minoxidil for hair losses. So upon examination, vision is 6.9 with IOP 16 and anterior segment were normal. So fundus examination, there's an elevated yellowish subretinal lesion about half this diameter in size, nasally to the fovea with no vitritis seen. So OCT macula show outer retinal hyperreflective lesion with a minimal SRF. So at that time, our impression was left eye subretinal fibrosis with differential of CSCR. So he was advised to stop consuming minoxidil and given 3 weeks follow-up review. So on second visit, the vision is worsening to 636, and we can see here the OCT macula show focal outer retinal hyperreflective lesion with SRF, and fundus autofluorescence show discrete central hyperautofluorescent lesion with surrounding hypoautofluorescent halo suggesting outer retinal RPE involvement is seen in active cases lah. So management, this one we screen patient for infection screening, and also we our working diagnosis at that time was left eye punctate outer retinal toxoplasmosis, and we started him on the Bactrim BD dosing for 6-week duration. So on the third visit, we can see there's a improvement in terms of vision, and patient also already started on tapering dose of oral prednisolone for 6-week duration. So on the final visit, we can see after completion of treatment, vision came on 6.6, and we can see the subretinal lesion become more smaller and become more hyperpigmented, with focal outer retinal hyperreflective lesion become flatter with complete dissolution of SRF. So investigation review, all the investigation were normal, including the viral screening and VDRL, and there's no evidence of tuberculosis. However, our toxoplasma serology, including IgM and IgG, is negative, and this test was done twice throughout the visit. So actually, seronegative is not common to be seen in toxoplasmosis patient, but there's several factors that can cause a seronegative, such as false negative serology in immunodeficiency patient, very early infection, in localized ocular infection, immunocompromised patient, and can be because of the wrong diagnosis. So this is a differential diagnosis for atypical with seronegative. And for diagnostic approach in an immunocompetent but seronegative pod, usually if the serology is negative, we can proceed with ocular fluid testing, such by performing anterior chamber paracentesis and vitrostep to look for PCR for the Toxoplasma gondii and also Goldman-Whitmer coefficient for intraocular antibody synthesis. This one is a literature review that I found out published in 2020. There's a study found that immunocompetent women presented with 2-year history of recurrent panuveitis, but is not responsive with systemic antiviral therapy. And also the Toxoplasma serum antibody is negative. So they proceed with acute fluid testing by PCR and it was positive for the Toxoplasma and patient improved after starting systemic anti-Toxoplasma therapy. So my limitation for this case is one is reliance on the clinical diagnosis in resource limited setting and also lack of advanced imaging such as FFA and also ICGA and also limited laboratory access for ocular fluid analysis where this is an invasive procedure and is not a routine option everywhere. So in summary, this case describes the presentation of an immunocompetent patient with seronegative pod. It could be possible, seronegative could be possible in immunocompetent patient, and pod lesion may be small yet require optimal management because of the macular location. That's all. Thank you.
Thank you. Thank you so much, Dr. Ariana, for this wonderful presentation with a nice take-home message. Can we have the perspectives of our panelists? Dr. Isha, if you can share your perspectives, please.
Yeah, hi. Congratulations, Dr. Ariana, on this presentation.
Thank you.
Actually, I'd like to ask that, can you show me the image again when presented?
The first visit, is
The
it?
first image, right?
This one?
Yeah, right. So, like, what all you suspected other than like toxo? Because what do you think is the classical picture of a toxoplasma that we usually see?
For ocular toxoplasmosis, usually they presented with a very choroidal retinitis with also a vitreous haze, vitritis. This is an
Right.
ocular
So,
toxoplasmosis.
basically, in the OCT also, I think there was a choroidal elevation as well. Can you show?
This one, is it?
Right. Right. So you said that in the first picture you thought that this could be a CSCR.
From the initial presentation because of the history of minoxidil, because minoxidil is a non-respector for CSCR also.
Okay, okay. So like if at all there is some elevation at the choroid and if there is a choroidal granuloma also that we can suspect. So the DDs related to that can also be considered.
Yeah, tuberculosis, one of the diagnosis, differential
Exactly.
diagnosis.
Right, right. So it's good, like good documentation. And I think it got managed well as well along with your treatment that you have given.
Okay, thank you, Doctor.
Okay, thank you.
Thank you.
Thank you, Dr. Isha.
Just wanted to have one clarification from the speaker.
Yes,
Yeah.
yes.
So,
Yes,
Dr.
Doctor.
Ariana, a very well documented case. So, did you also add oral steroids post toxoplasma therapy? Or?
Yes, we add oral steroid 72 hours post antiparasitic treatment.
Okay, fine. Thank you.
This one.
Thank you, Dr. Ashish, for that important question. I think Malaysia has left no stone unturned, be it from infection to inflammation. Everything has been covered. Now we move on to the next country. Before that, do we have Dr. Nahal? Okay.
No, I can't seem to connect to Dr. Nahal. You can move ahead with the other participants.
Okay, sir. Okay. So next we have Dr. Shafiq from Pakistan. And I request Dr. Shafiq, Dr. Ariana, if you could please stop screen sharing. Dr. Ariana, kindly requesting you to stop your screen sharing, please. Yes, thank you. Dr. Shafiq Tanveer.
Yes, am I audible?
Yes, Dr. Shafiq, yes. And we can see your screen as well.
Okay. Wait.
Yes. Please take your time. That's okay.
Good evening.
Yes.
My name is Shafiq Tanveer. I am from Khyber Teaching Hospital, Peshawar, Pakistan. And today I'm going to present a case report on bilateral rheumatogenic retinal detachment in a young adult with neurofibromatosis 1. So neurofibromatosis basically is a group of phacomatoses characterized by various genetic disorder, often marked by development of nerve sheath tumor. There are three types of neurofibromatosis: NF1, which is the most common one, NF2, which comprises 3%, and schwannomatosis. And it is an autosomal dominant condition and it affects multiple bodily systems. Multiple tumor associated with NF1 include retinal astrocytic hematomas, multiple retinal capillary hemangiomas, and combined hematomas, which can lead to complications like neurovascular glaucomas, vitreous hemorrhage, and retinal detachment. The ocular manifestation of neurofibromatosis include cafe au lait spots, axillary and groin freckling, and dermal tumors. And the ocular manifestation include optic nerve pathways, gliomas, and leash nodules. We present a case of a 33-year-old hypertensive male who basically presented to our outpatient department with high blood pressure, but he was clinically diagnosed at NF1 considering the presence of cafe au lait spots, multiple subcutaneous nodule, and a positive family history of neurofibromatosis. He was sent to ophthalmology department for ruling out ocular manifestation, and what we saw was the visual acuity of 20 by 200 in both eyes, leash nodules on the iris, and bilateral rheumatogenic retinal detachment upon dilated fundus examination. These are some of the pictographical presentation of the patient. As you can see from the fundus photograph, that in the right eye there is a superior rheumatogenic retinal detachment involving the macula with proliferative vitreoretinopathy as seen by the blue arrow. And there was also superotemporal tears, and in the left eye there was long-standing RRD as evident by the retinal cysts that are present superonasally. There was no family history of trauma, no family history of rheumatogenic retinal detachment, no trauma, and ocular surgery history, or no ocular manifestation, etc. So basically, we wanted to rule out the history of trauma because the patient also had retinal dialysis in the left eye. This case presentation basically points out that in NF1, the patient can present with multiple different ocular features, including bilateral spontaneous retinal detachment, which could be explained basically by the suboptimal fibroblast in hereditary conditions like these, which lead to the abnormal collagen fibril formation, and hence the attachment of the vitreous base to the peripheral retina is not very strong, due to which it can lead to oral retinal dialysis, ora serrata dialysis, and subsequent rheumatologist retinal detachment. This case reports highlight an interesting incidental finding in a patient with NF1. And to our knowledge, ours is the first case to demonstrate the presence of bilateral RRD in the patient with NF1. The take-home message is that conduct comprehensive eye exam in all NF1 patients regardless of the symptoms, because early detection of retinal changes can prevent severe visual loss. Always maintain a high index of suspicion for subtle retinal abnormalities in NF1. With this, I thank you all.
Wow. Hats off to the timing, Dr. Shafiq. So bang on
Thank
target. Can I request Dr. Atif Markan sir to share his 2 cents on this case, please?
Yeah, thank you, Dr. Shafiq, for this interesting case. So did your patient also had retinal dialysis in the right eye also? Or was it present only in the left eye?
Only in the left eye.
So I think it is incorrect to actually hypothesize that neurofibromatosis had some glial tissue probably causing dialysis in one eye and a retinal tear in the other eye. Very unlikely that the hereditary component is the cause of dialysis in one eye and there's a supratemporal tear probably and is unrelated to dialysis.
There
in the other
actually,
hand?
the dialysis is typically associated with significant blunt trauma, such as sporting injuries or assault. So we were basically, on repeated questioning, the patient denied any history of trauma. And from the literature review, we have also seen some cases of unilateral rheumatogenic retinal detachment secondary to dialysis in NF1 patient. That's why we suspected this.
Okay, so do you know of any other condition where there is no trauma but patient can have dialysis in both the eyes?
In both the eyes?
Yeah.
No, sir.
Not an issue. Thank you.
Thank you, sir.
Thank you, Ashish sir, for your valuable questions. Next, from Pakistan, we move on to Philippines. Quite far apart, but I think coming together on Noinadi. So we have Dr. Jed Mikhail Tabankura. And Dr. Jed, are you there with us? Yes, I can see your video.
Hello, good
And
evening, everyone.
good evening, good evening. Kindly screen share, please.
Okay, just fix my slides.
Yes.
Can everyone see my
Perfect.
slides?
Yes, yes. Please go ahead.
Okay. May I start, sir?
Yes, yes, Dr. Jed, please
Okay,
start.
good evening, doctors. My name is Jed Damacura, 3-year resident from Manila Doctors Hospital, Philippines. I will be presenting my case of bilateral combined retinal artery and retinal vein occlusion in a young patient. I have no financial disclosure for this case. Our patient is MGD, a 27-year-old female with chief complaint of blurring of vision of both eyes. 2 months prior to admission, patient felt an unrecalled debris on the right eye, followed by BOV and floaters. She was initially assessed as corneal abrasion and managed with tobramycin and BCL with symptom relief. 1 week prior to admission, she presented with patchy BOV with floaters on the left eye, accompanied by severe pain, which prompted consult and subsequent admission. For the past medical history, it's generally unremarkable with only known history of oral contraceptive use and smoking. Review of systems is also unremarkable. BCVA is 2400 for the right eye and 2200 for the left eye. External eye examination and slit lamp examination findings are generally unremarkable. We had the benefit of a fundus photo which showed attenuation of vessels with diffuse areas of retinal whitening at the macula. There are also multiple intraretinal hemorrhages along the superior arcade with a cherry red spot lesion on the macula for both eyes. At this point, our primary impression is retinal artery occlusion of both eyes. FA revealed delayed arterial and venous filling time, as well as pruning of several branches of the retinal vessels. Also noted was incomplete retinal vessel filling, retinal vascular staining, and severe widespread capillary non-perfusion on the later phases. Macular OCT was done on a different day, which showed retinal thickening of the inner layers with false posterior shadowing and cystoid macular edema. Further investigation showed elevated ESR and CRP levels with positive results for ANA and P-ANCA. FBS, lipid profile, and bleeding parameters were all within normal range. Cranial MRI with contrast showed no signs of encephalopathy. At this point, our diagnosis was combined retinal artery and retinal vein occlusion secondary to ANCA-associated vasculitis with macular edema of both eyes. For a short discussion, combined retinal artery and vein occlusion arises from mechanical, vascular, and systemic factors, primarily due to arteriovenous compression at the lamina cribrosa. It may be aggravated by systemic vascular or hematologic abnormalities, and in young patients is often linked to hypercoagulable or inflammatory conditions rather than age-related disease. Prognosis is generally poor with higher risk of complications. CRAO was ruled out and diagnosis was based on retinal whitening with multiple hemorrhages and dilated veins, and FA showing delayed filling in both arterial and venous phases, confirming a combined occlusion, and Susak syndrome was ruled out due to absence of encephalopathy and hearing loss. For the management, we initiated IV methylprednisolone therapy with the help of internal medicine for 3 days with oral tapering for 4 weeks. 1 month after, repeat OCT showed resolution of macular edema with generalized macular thinning on both eyes. Repeat fundus photo and FA showed prominent ghost vessels, disc neovascularization, and massive capillary non-perfusion, with non-perfusion involving the macula on both eyes. Further management, PRP was done on both eyes for the NVD, and subsequent recurrent vitreous hemorrhage prompted an as-needed treatment of anti-VEGF injection for both eyes. And after 12 months of initial treatment, vitrectomy with endolaser was done for the right eye. However, BCVA was still 2400 for the right and 2200 on the left. In conclusion, systemic vasculitis is a known cause of retinal vaso-occlusive disease in the young. ANCA-associated vasculitis, though rare, may initially present with blurring of vision. In this case, severe retinal ischemia and macular thinning in both eyes led to poor visual prognosis despite treatment. And management of systemic disease remains essential to reduce morbidity and mortality. And clinicians should be vigilant for ANCA-associated vasculitis to prevent complications, especially in young patients. And for my take-home message, think beyond the eye. In the young, retinal occlusion can mean systemic vasculitis, but it early, treat it fast, and save sight and life. Thank you.
Thank you, Dr. Jed, for being right on time. So now can I invite Dr. Nawasish ma'am to share her perspectives?
So, well presented case. If I could just ask you, what other manifestations could be for ANCA-related vasculitis, systemic manifestations, and ocular?
For the systemic magnifications, in ANCA-associated vasculitis, patient may also present with painless unilateral vision loss and also perivascular sheeting or in the fundus. For the systemic manifestation, for systemic manifestations po, patients may present with
So my basic, the reason I'm asking you this is because we tailor our investigations, correct? So what manifestations would be present in a patient for you to suspect whether it is ANCA-related vasculitis or any other systemic illness-related vasculitis? So what features did you see in your patient to ask for ANCA investigations for ANCA?
because our patient presented with small vessel vasculitis in the
So
ocular
what about doing
examination.
APLA for this patient? What about testing for APLA antibodies, antiphospholipid antibodies?
Yes, in this cases, we should also consider antiphospholipid antibody syndrome, especially the patient is in a reproductive age.
Okay. Thank you.
Thank you, ma'am. Thank you for your valuable insights. We are going on to the last international presenter for today's evening, all the way from Vietnam, Dr. Hong. Dr. Hong Bui. Are you there with us, doctor?
Okay, I think he's not available. Maybe we'll call the next speaker. In the meanwhile, we'll call him.
Yeah, I'll try to contact him. Dr. Amit Nandan Tripathi.
So I'll hand over the moderation to Dr. Pranay sir and Dr. Karthikeyan sir. So with that, I think if Dr. Hong and Dr. Hal join us, we'll take it forward from there. Thank you, sir. Over to you.
Yeah.
Thank you, Nandan. Pleasure. So next we'll have the presenter, Dr. Amit Nandan Tripathi from India on open globe injury.
Dr. Amit, are you available? Can you, if you are mute, just unmute and speak. Dr. Amit. I don't think, I can't say his name.
Okay, no issues. Can we move ahead to Dr. Arpit Gupta?
Yes, sir, I'm here, sir.
Yeah, Arpit, doctor, you can present, doctor, please.
Is my screen visible, sir?
You are visible, your screen is not visible yet. Yeah, your slides are visible, doctor. You can start.
Timer. Niranjan, you have it. Yeah, fine.
Started. Yeah. You can go ahead, doctor. Full screen.
Sir.
Yeah, visible.
So, good afternoon, everyone. Here I am to present a case of alopecia universalis, which is as a presenting feature of acute VKH syndrome. So, we had a 19-year-old male with complaints of progressive hair loss for past 3 months who came to dermatology OPD and was referred to Ophthalm for complaints of painless progressive diminution of vision in both eyes for past 2 weeks. So patient was apparently normal for past 3 months, and hair loss was initially noted in the scalp and extended to his upper limbs, beard, and axilla. And for 6 weeks after the initial presentation, he developed gradual painless diminution of vision in both the eyes, and there was no associated complaints. There were no significant positive findings. Past history was non-significant. There was no significant complaints in the past. There was no similar complaints in the family members as well. So coming to the general examination, vitals were within normal limits, and on head-to-toe examination, loss of hair was noted on beard, chin, his head, and there were sparse hair noted on axilla, upper limb, and chest. And there was no evidence of hearing loss in the patient. Then coming to ocular examination, patient's head position was erect, eyeballs positions were orthotropic. Uncorrected visual acuity in right eye was 6.9, which improved to 6.6 parts on pinhole. And on eyebrows and eyelashes, there was madarosis present. Rest anterior segment evaluation of right eye was within normal limits. And there was anterior chamber was Van Herix grading 3, and there were no cells. And there were no retrolental cells as well. On left eye, their vision was 6.12, which improved to 6.9, and there was madarosis present. And the anterior chamber was within normal limits, and there was no evidence of AC cells or retrolental cells. Coming to the dilated fundus examination, in right, both eye medias were clear, and in both the eyes, in right eye especially, there were parafoveal exudative retinal detachment was noted temporally and inferotemporally of around 2 disc diameter in size. And in the left eye, it was involving the macula, causing exudative retinal detachment. So with this, my provisional diagnosis was most likely pointing towards what VKH syndrome. And the investigations we did were initial baseline chest X-ray and Manto test, which were within normal limits. And on OCT macula, it revealed serious retinal detachment. Right eye, it was parafoveal, and left eye, it was just below the fovea. And coming to FFA, in late venous phase, here we can see the late venous phase, which shows us multiple pinpoint hyperfluorescent leaks with late pooling. And also in this eye, we can see the retinal detachment part, which is the exudative RD part, which is shown by the pooling here in the image. Then coming to the B scan, it showed increased RCS thickening in both the eyes. So coming on to the management, so from dermatology side, for alopecia universalis, they started the patient on tofacitinib. And when we diagnosed acute VKH, we considered stopping tofacitinib and started on high dose oral steroids. So patient was given tablet prednisolone 70 mg OD with weekly tapering along with topical steroids. And on follow-up, patient vision actually improved to 6.6 and RD resolved. Here you can see that whatever RD we saw in the previous picture is not there. And OCT also was within normal limits. And the patient clinical picture, patient actually age group, and the patient started growing sparse hair. This is the final image. So take-home messages, the dermatologist should be aware that in extensive alopecia, systemic autoimmune disease workup should be done. And early corticosteroid can lead to complete visual recovery. Thank you.
Great presentation, Dr. Arpit. Now we'll go on to the panel, Dr. Mohammad Azam, to ask a few questions on this case. Dr. Azam?
Hello. Can you hear me?
Yeah.
Yes, sir.
Very clear and audible, sir, please.
Okay, so what about any atypical presentations? What would be your criteria in deciding to treat if it is for VKH or not?
They're atypical, like this is atypical presentation because the integumentary findings we actually find in chronic VKH, but here it presented acutely, and we considered this as VKH.
Okay, thank you.
was a great presentation, Doctor. Great to have you here, Dr. Arpit. Now we'll go on to the next presentation, Dr. Anna Abraham.
Thank you, sir.
Thank you very much. Thank you very much. The presiding judge will be Dr. Shreyas. Dr. Annie, yeah, your video is on, Doctor. Can you start your presentation?
Right, sir.
Yeah, perfect. I think your screens are yet to be visible. Yeah. You can, Doctor, the thing is you have to, hide the box of the Zoom. We can see a small gray box above. Go above, go to settings, and then hide the, yeah, hide the floating window.
Or you can start a slide share, it will get over, I think. Yes. Oh, but still it's there.
Still it's there, yeah. You can press escape and you can just hide it. Options.
Sir, is it okay now?
Yeah, it's perfect, Nama. Central, there's some grayish dot, but that should, yeah, no, it's gone. Yeah, go ahead, you can start. All the best, Doctor. Thank you.
Good evening, all. I'm Dr. Anna Abraham, second year ophthalmology resident from Command Hospital, Eastern Command, Kolkata. Today, I'm presenting a case of a 43-year-old female who presented with complaints of. Sir, is my tab working, sir?
Just press on the screen and press your arrow button, Doctor. It will work.
Okay. A 43-year-old female who presented with complaints of bilateral floaters of 2 months duration with a recent onset of bilateral parotid swelling on and off low-grade fever. There was no other significant ocular complaints. There was history of low backache, which was not associated with any other joint pain or morning sickness of joint. There was history of a nodular swelling over there, which was present since past 1 month. And there was no history of any cough, chest pain, shortness of breath, no history of any skin rash, oral or genital ulcer. In the past medical history, she was having significant history of weight loss, around 8 kgs in the past 6 months, associated with chronic fatigue. On ocular examination, her best corrected visual acuity in right eye was 6/6 and left eye was 6/12, and IUP was within normal limits. Anterior examination in both eyes showed pigmented keratic precipitates in the Arles triangle, and retrolentally 1+ cells was present in both the eyes. This is a picture showing pigmented keratic precipitates in the right eye and 1+ retrolateral cells. Similar picture of the left eye. The right eye fundus examination showed a normal optic disc, and in the vessels you can see inferior nasally segmental periphlebitis was noted. And in the left eye, the nasal margins of the optic disc was blurred, suggestive of optic disc edema, and there was superior temporal and inferior temporally segmental periphlebitis was noted, which was suggestive of posterior uveitis. So my differential diagnosis was posterior uveitis both eyes, left eye more than right eye, intermediate uveitis both eyes, and probably of non-infectious etiology. An OCT macula was done in both eyes, which showed in the vitreomacular interface there was few vitreous cells suggestive of vitritis, low grade, and fundus fluorescent angiography was done which showed in the late venous phase in right eyes segmental periphlebitis, staining of vessels was seen, and in the left eyes there was hyperfluorescence of disc suggestive of disc edema. While investigations were underway, she developed a left-sided facial nerve palsy. And the investigation showed lymphopenia, significant lymphopenia of 8.5. ESR was elevated, mild CRP was elevated, Montes test was negative, and CECT chest showed significantly enlarged hilar and mediastinal lymphadenopathy, which was suggestive of stage 1 sarcoidosis. And serum AC was elevated, around 150. This is CECT image of the patient showing 33 mm size of a hilar lymph node, which suggestive of without any lung parenchymal involvement. So it's a case of a bilateral hilar lymphadenopathy in CECT, left-sided facial nerve palsy, and segmental periphlebitis with disc edema suggestive of posterior uveitis, and bilateral parotid gland enlargement, which is key features of a syndrome which is associated with sarcoidosis, that is Herford-Waldenström syndrome. So we started her on corticosteroids, and she responded well with full recovery of vision in her left eye, which responded to 6/6. And she was also referred to pulmonologist for stage 1 sarcoidosis. Her pulmonary functions was within normal limits. EBUS TBNA was also done, which showed non-caseating granuloma. So the take-home message is the patient responded well to oral corticosteroids with resolution of ocular and systemic symptoms. This case highlights the importance of recognizing Herford syndrome as a distinct clinical presentation of sarcoidosis, particularly in patients with ocular and neurological findings. Early diagnosis and appropriate systemic therapy can lead to excellent visual and functional outcomes. Thank you.
Great, doctor. Great. Now, can we have the respected Judge Dr. Reyes sir to ask a few questions?
Yeah, it was a very well documented and managed case, Dr. Anna. So I have two questions here. So actually, going by Sun classification, actually retinal vasculitis doesn't come under posterior uveitis. So
Yes.
vasculitis is not at all included in Sun classification. I think maybe you need to rectify your diagnosis. You just mention it as retinal vasculitis rather than mentioning it as posterior uveitis. Because
Right.
when we have retinitis or choroiditis, then only we label it as posterior uveitis. So then one more question is that here I think the diagnosis is presumptive. So did we do any lymph node biopsy of the enlarged hilar lymph nodes? Like did the
Yes,
pulmonologist
sir.
confirm?
In EBIS TBNA, sir, non-casheating granuloma was found, sir.
Okay, was that mentioned or I missed it? I'm not sure. Like,
It was mentioned, sir, but I did not get a picture of the slide actually to portray in the.
okay. So it was a confirmed case of sarcoid.
Yes, yeah, right, sir.
Okay. Otherwise, it's a very well documented and managed. So congratulations on it. Thank you.
Thank you, sir.
Thank you, Ani, for your presentation. Now we go on to the next presenter, Dr. Kirtana R.
Yes,
You
sir.
can exit your slide share, doctor. Thank you, Dr. Anna.
Hello.
Yeah, you can present, doctor. You can present. She's doing a presentation on retinal vasoproliferative tumor. So, yeah. Slides are visible, doctor. Slideshow?
Sir, can I start, sir?
Yes, please. You can start. Go ahead. All the best.
Okay, sir. Um, a 60-year-old gentleman presented to us with diminution of vision in right eye for the past 1 year, which was gradual in onset, painless, progressive in nature, associated with flashes of light and floaters. He is not a known case of any known comorbidities. General examination and systemic examination was within normal limits. And on ocular examination, his visual acuity in right eye was 3/60. PR was accurate. Left eye visual acuity was 6/24 with no further improvement with pinhole. Right eye, he was pseudophakic, and left eye had immature senile cataract. Rest anterior segment examination in both eye was within normal limits. Coming on to dilated fundus examination of right eye, which showed an elevated orangish mass lesion measuring approximately 3x2 disc diameter, located 4 disc diameter temporal to the fovea, with telangiectatic vessels could be seen over the surface of the lesion, with surrounding lipid exudation and retinal thickening. Also, dispersed VH was also noted. Left eye fundus examination was within normal limits. A provisional diagnosis of right eye pseudophakia with left eye IMSC with right eye retinal mass lesion was made. And considering the differentials being retinal vasoproliferative tumor and retinal metastasis. So, based on the history and the clinical examination, points in favor of retinal VPT in this case was the location of the lesion, which was temporal, and appearance of the lesion, which was orangish and elevated, and the presence of prominent retinal feeder vessels and marked art exudates. Also, there was no history suggestive of any other systemic association, and further confirmation can be made out by USG and fluorescent angiography. So these were the panel of investigations which was ordered to the patient. And in B-scan ultrasonography, it showed an homogeneous mass with high internal reflectivity, suggestive of vasoproliferative tumor. And OCT showed focal vitromacular traction causing the distortion of the foveal contour. And fundus fluorescent angiography showed early hyperfluorescence with progressive late leakage of the lesion. Also, there was a few blocked fluorescence corresponding to the areas of vitreous hemorrhage. Further blood investigations and systemic evaluation was done to rule out any systemic metastasis, in which no abnormality was detected. So the diagnosis of primary retinal vasoproliferative tumor with VMT was made, initially treated with intravitreal anti-VEGF and triamcinolone acetonide. This was the fundus image post-op day 1 after injection. Here we can see visible intravitreal triamcinolone particles. And following injection post-op 1 month, it resulted in decreased retinal edema surrounding the lesion. But still that VMT was there, for which the patient underwent pars plana vitrectomy plus VMT release plus cryotherapy plus endolaser photocoagulation. This is the surgical video of the same. We can see core vitrectomy is being done and PVD induction was done using triamcinolone acetonide, not induced near the fovea to avoid deroofing. Then cryotherapy has been applied and laser photocoagulation has been done. So this is the fundus image post-op 1 week of the PPV. Significant tumor regression has been noted, and over the past next 6 months, the patient underwent 2 sessions of laser photocoagulation and 1 additional cryotherapy session was given. So this is the outcome of the patient. 3 months post PPV, tumor regression was noted with fibrosis and surrounding retinal thickening resolved completely. And OCT also showed restoration of the foveal contour and continuity of the all layers were noted. And the best corrected visual acuity was 6/18. So take-home points from this case: retinal VPTs are rare benign vascular tumors that can cause vision loss due to secondary effects. In this case, it was VMT. Diagnosis is mainly clinical and multimodal imaging helps in confirmation. And it requires multiple treatment sessions, and pars plana vitrectomy is to be done in cases of complications like VMT, ERM, DH. Thank you, sir.
Great presentation, Dr. Ketna. We'll have Dr. Our respected Dr. Ashish Markan to ask a few questions to them.
Yeah, thank you so much, Dr. Kirtana, for amazing presentation. But did you also suspect it to be a retinal angioma post VHL?
Usually
Why did you make a diagnosis of a primary vasoproliferative tumor and not a retinal angioma?
Retinal hemangioblastoma, usually age of presentation can be young age onset.
What was the age of the patient in your case?
This patient, 60 years, elderly patient.
Okay, so what do you think the cause of VPT was there in your case? You could actually see the feeder artery and the vein draining venule from the tumor.
Yes,
so I think the first diagnosis or the first differential should have been a retinal hemangioblastoma or the retinal angioma, as we say it.
Okay, sir.
Not VPT, because you see the management would not change much. You did cryo, obviously you did a cryo, you lasered around that site. Obviously the tumor had to regress, but it is important to make to keep in consideration that it could be a retinal angioma post VHL, because even if you treat a single angioma, it might recur at some other site or it might recur in some other in the other eye of the patient. So
Okay,
I
sir.
think that differential should have been kept in the mind. Otherwise, beautifully managed case. Congratulations.
Okay, sir. Thank you, sir.
And great comments from Dr. Ashish. Now we can go on to the next presentation, Dr. Nishi Prasad. The presiding judge would be Dr. Shreyas. Dr. Nishi?
Dr. Nishi, if you are available, kindly unmute yourself and speak. I don't think. Yeah, Dr. Nishi is not available.
Not available. Okay, so the next presenter after Dr. Nishi is Dr. Neelam Kumari. Presiding judge is Dr.
Yeah, Dr. Neelam is there. You can unmute yourself.
Yeah. Your slides are visible, doctor. You can start your presentation now. You can start from the starting, doctor. Yeah, you also can start, doctor.
You are not audible, Dr. Nishi. Dr. Neelam, you are not audible.
Yeah, Dr. Neelam, you're not audible.
Can we have the timer again? Yeah.
Yes, sir. Sure.
No, that
Yeah,
should
now
not be
you're
a
audible.
problem.
Now you're audible.
Yeah, you can start now, doctor.
Good evening, everyone. I'm here to present ectopic fovea in young patient. A 23-year-old male student by occupation presented in our hospital with chief complaint of progressively worsening blood vision in left eye since childhood. Medical and ocular history were unremarkable with no trauma, systemic disease, or family history of the retinal disorders. Visual acuity. UCVA of right eye was 618 partial and left eye was 260 with pinhole 66 partial in right eye, 260 in left eye. BCVA in right eye was 66 partial in left eye, 260. On examination, anterior segment was within normal limit. Posterior segment of right eye, media was having a few temporal vitreous floaters. Disc was normal, vessels was normal, background was normal, foveal reflex was dull. While in left eye, temporal vitreous floaters were present, CDR 0.7 and disc pallor. Abnormal peripapillary vessels were present, tessellated background with inferior lattices degeneration. Inferonasal foveal displacement consistent with an ectopic fovea. This is the image this is the OCT, shows absence of normal foveal depression at its usual location. A distorted foveal contour was identified inferonasally, confirming an ectopic fovea. Retinal layers were otherwise normal with an intact ellipsoid zone and no cystoid edema or traction. Fundus photo of right eye was normal, while left eye first arrow shows abnormal contour of arcade vessels, and CDR was 0.7 disc pallor, and third arrow shows fibrotic membrane arising from the nasal part of the optic disc, and the fourth arrow shows inferonasal foveal displacement. Fluorescence angiography to rule out any abnormal retinal perfusion with leakage, staining, or capillary dropouts in the macular region, ruling out inflammatory or neovascular cause for the displacement. Patient was asked to do FA on next visit, but he didn't follow. A diagnosis of ectopic fovea was made based on clinical and imaging findings. The condition appeared non-progressive with no signs of retinal dystrophy or degenerative disease. Management and follow-up. No surgical or medical treatment was required due to the stable retinal structure and absence of the treatable pathology. The patient was counseled about the condition and advised to use low vision aids for daily tasks. Regular 6-month follow-ups were planned to monitor retinal status and vision. At the latest visit, visual acuity remained stable and no OCT detected progression. Differential diagnoses are foveal hypoplasia, macular dragging due to the retinopathy of prematurity, tractional displacement due to the epiretinal membrane, vitreomacular traction, macular hole formation, chorioretinal coloboma involving macula, retinal dystrophies, post-surgical post-traumatic macular displacement, high myo. Take-home message: ectopic fovea, though rare, should be considered in a case of the unusual visual impairment or atypical macular findings. Clinical examination and OCT are essential for identifying and characterizing this anomaly. Early detection help diagnose it from other macular disorders and guide proper management. Ongoing follow-ups and the visual rehabilitation are important for maintaining quality of life. Discussion. Ectopic fovea is a rare retinal anomaly in which the foveal pit is displaced from its normal macular position. It may occur with the retinal dystrophies, congenital malformation, or acquired retinal damage. Its exact cause is unclear but may involve disrupted foveal development or traction remodeling from degeneration. The patient shows marked visual reduction in the affected eye corresponding to the displaced fovea. Despite this, functional vision was preserved, suggesting neuroretinal adaptation with the eccentric fixation. Previous reports have OCT to be essential for assessing foveal structure and retinal layer integrity. Advancing imaging remains crucial for the diagnosis and the long-term monitoring for any degenerative changes. Thank you.
Thank you, Dr. Neelam. Great presentation. We'll have the closing comments from the judge, Dr. Nawaz, and from our panel, Dr. Isha Acharya. Dr. Nawaz.
Great presentation. Could you tell me what was the axial length for this patient? Was axial length done?
No, ma'am.
So you could have done an axial length for this patient. It could be a unilateral high myope, something associated with tilted disc syndrome, but that could possibly add to your diagnosis as well. Good presentation. Thank you.
Thank you, ma'am.
Also, a few words from our question from judge, Dr. Panel, Dr. Isha.
Great documentation, doctor.
Thank you, ma'am.
Basically, I wanted to know, like, there is a disc drag, right? So what was the cause you have, like, what was the cause you were searching for? Why is the
Um,
disc drag unilaterally present?
Maybe due to some fibrotic membrane, which was shown in OCT image. Oh,
So did
sorry.
you see any peripheral changes in this patient?
No, ma'am, there was nothing in the periphery.
Nothing. Okay. So there has to be some cause when there is a disc drag. So probably wherever the drag is going, you could have surge in the periphery, in the nasal periphery. So
Yes, ma'am.
rest good documentation.
Thank
Thank
you.
you.
Thank you, Isha madam. Next contestant, we have Dr. Shashi Kumawat on case presentation on discrete maculopathy. Dr. Shashi? Is Dr. Shashi there? Okay. We will move on to Dr. Priyanka Narula. Case on VKH. Is Dr. Priyanka there? Hello?
Yeah, you are audible, Pranesh.
Yeah. Dr. Shashi Kumawat and Dr. Priyanka Narula.
We'll call them Pranesh. You can move. I think Priyanka is here. Dr. Priyanka is here.
Good evening.
Yeah. Great, Dr. Priyanka. You can share your presentation, please.
Is it visible, sir?
No.
No. Okay, wait.
Can you try once again?
Yeah, sure, sir. Is it visible now, sir?
Yeah, it's visible now, doctor.
Okay. I'll be starting. Good evening, everybody. I'll be presenting a sorry, it's not working.
Keep your mouse inside and click. Yeah, perfect.
Good evening, everybody. I'll be presenting a patient of female, age 50-year-old female, came with a chief complaint of gradual painless progressive diminution of vision in the left eye since 10 years. It was associated with ocular pain and photophobia. So the history dates back to April 2025 when patient had this complaint and patient got an ophthalmology consultation for the same and was told to have developed inflammation in the left eye and was started on oral steroids and there was some relief in the symptoms. Now on the initial presentation, so there was no history of any associated redness of the eye, no history of any previous ocular surgery or trauma to any eye, no history of usage of glasses, and there was no history of any previous episodes like that. Patient was a known case of diabetes mellitus and was on oral hypoglycemic agent since 5 years. So on initial examination, when we saw the patient, the left eye vision was 660, the best corrected was 612. The IOP was within normal limits with an anterior segment reaction and vitritis of grade 2 plus. On examination of the fundus, we saw that left eye had isolated multiple yellowish lesions measuring half this diameter located at a posterior pole with ill-defined margins at the level of the choroid, which was confirmed via the FFA. Multiple hyperfluorescence foci with pinpoint leakages were seen. After that, a provisional diagnosis of left eye multifocal choroiditis was made and, left eye multifocal choroiditis was made and patient was continued on oral steroids 60 mg for 10 days followed by tapering every week according to the body weight and following uveitic panel investigations were ordered. Patient followed up after 3 weeks. The vision in the left eye improved to 6-9 parts with occasional activity which was seen and patient was continued on oral steroids. All the blood investigations came out to be within normal limit. Patient followed up after 2 weeks and we saw that the patient was maintaining vision in the right eye and the fundus was within normal limits. In the left eye, the vision deteriorated to 6/60 and there was an ill-defined active lesion involving the fovea. So it was a fovea threatening. So patient was given IV methylprednisolone 1 gram OD for 3 days and then it was maintained on oral steroids. Patient followed up till 1 month. Patient had uncontrolled sugar because of which we had to stop the steroids and patient was given posterior subtenon injection of triamcinolone in the left eye, after which the patient lost to follow-up. So patient then presented after 2 months. On that, patient came with a sudden painless diminution of vision in the right eye. The vision was around finger counting 1 meter. The pressures were normal. There was activity both in anterior segment and in the vitreous in both the eyes. The right eye fundus shows bullous serous retinal detachment and the left eye showed pigment clumping. FFA was done and OCT for the right eye. The FFA showed pinpoint hyperfluorescence and there was coalescence with the optic disc leakage, and the OCT was done showing subretinal fluid. So after all the investigations and taking into account the presence of the exudative detachment in the right eye with depigmented fundus look in the left eye, a diagnosis of probable VKH was made. Patient was given IV methylprednisolone 1 gram OD for 3 days for the right eye now, and the tablet azathioprine 100 mg OD was started with a CBC, LFT, RFT screening test done and a rheumatology consultation was done. Post IV methylprednisolone, the vision in the right eye improved for 6/24. The exudative retinal detachment that settled down. Now, after 1 month of the treatment with oral steroids and immunosuppressants, this is the current, the vision in the right eye is 624 and left eye is 660. So on the fundus of the right eye, we showed depigmentation and pigment clumping of the RPE. With the left eye, there was a presence of a macular scarring. That's why the vision was 660. The incidence was thinning of the choroid of the RP, and the right eye FFA still shows a hot disc. So the challenges we faced during the management was the use of the oral steroid, the compliance, the patient was diabetic, there was tapering of the steroids too early led to recurrences, and tapering too late led to systemic adverse effects. And there was an atypical presentation with no systemic involvement, and a long-term follow-up and patient belief was difficult to handle. So all the criteria of probable VKH was made, so that's why a diagnosis of that was made. Thank you.
Great, doctor. Now we can move on to our Judge Dr. Shreyas sir for his comments on this case.
Dr. Priyanka, well documented case, but I have certain doubts regarding the diagnosis.
Yes.
So looking at the presentation as such, I have a doubt of the diagnosis with VKH because whatever the presentation goes in favor of somewhat white dot syndrome. So initially it looked like an APMPP and subsequently it did not actually respond that well to steroids as such.
Yes,
It
sir.
was progressing further. So
Yes,
probably I would fit this diagnosis into case of relentless placoid choroidopathy.
Okay,
So,
sir.
or the amphigenous choroidopathy. So that would be the better diagnosis for this patient because VKH as such responds very well to steroids.
Okay, sir.
So in your case, actually the course was worsening.
Yes, sir.
So I think you have
First,
to.
initially it was a unilateral presentation, and then it went to a bilateral presentation. The exudative detachment came out late in the right eye, and
Yeah.
it was just a unilateral one initially.
And
But
again, VKH most often will be bilateral. So that is one
Yes.
point which we need to consider here.
Okay,
And
sir.
was OCT done at the initial presentation?
Yes, sir. It showed no like any. There was no any subretinal fluid which was present in the OCT. It was normal. There was no changes in the OCT.
Okay, so again, that is one point which might not be again favoring VKH because
Okay, sir.
usually acute VKH usually present with bilateral serous detachments.
Yes.
So probably I think you need to reconsider your
Okay,
diagnosis. So
sure.
okay, anyways, all the best.
Thank you, sir.
Thank you very much, Shreyas sir. For next presenter, we have Dr. Asma Jabin, please. Dr. Asma Jabin.
Yes, I'm here. Am I audible?
Great. Yeah, perfectly audible, doctor. You can go ahead. She's doing a case on epimutes, unusual case of epimutes.
I'm not able to share actually.
How much time would you need, doctor? You actually are sharing your whole screen. Yeah,
Is the
perfect.
presentation visible?
Yes, doctor. Yes.
Okay, hello
I'll start the
everybody.
timer, doctor.
It's an honor to be here as today's speaker. I'll be speaking about a case of 37-year-old female who presented in our OPD with chief complaints of diminution of vision in her both eyes, left more than right. She was also complaining of flashes of light in her left eye. Along with that, she had a history of earache with pus discharge 14 days prior to the symptoms. On examination, her visual acuity was 6.9 in the right eye and 6.24 in the left eye, which was improving to 6.6 in both the eyes. Interior segment findings in both the eyes were unremarkable. On fundus examination, right eye was normal, but on the left side, she had pinpoint yellowish white lesions, which were predominantly seen in the posterior pole and in the mid periphery. Her fundus autofluorescence showed somewhat mixed kind of picture. Few lesions were hypoautofluorescent, surrounded by hyperautofluorescent, and few were hyperautofluorescent. She was planned for angiography. These are FFA pictures which were taken at different time intervals. We can see that there were small punctate hyperfluorescent lesions which were seen in the posterior pole and in the mid periphery. Along with that, in the third picture, we can see there was hyperfluorescent lesion present inferiorly without any leakage in the later phases. Her OCT scans, right eye was normal. In the left eye, I'll show you this picture. We can see there was hyperreflectivity here and disruption of outer retinal layer was present. Then her visual fields were also done. Right eye was normal, but on the left side there was slight enlargement of the blind spot which was noticed. Then, keeping in mind certain differentials, we ordered certain systemic investigations, but they all came out within normal limit. So, going by all the multimodal images, a complete workup, her systemic investigations, we reached to the provisional diagnosis of multiple evanescent white dot syndrome in the left eye of the patient. After 1 month of follow-up, those lesions, they begin to disappear. If we compare her day 1 picture with 1 month follow-up picture, we can see I can barely detect any lesion on the after her 1 month follow-up. And this was her fundus photo from 6 months follow-up. On FF picture, again, barely any vision is any lesion is detectable. So this is since we know this was a self-limiting condition, patient was counseled for same. She's still with us on follow-up. Her vision and fundus findings are stable. There is no change in her autofluorescence findings. So the take key away points from here were it was a case with unilateral presentation, well-defined lesions predominantly in the perimacular and area and mid-periphery. And there on FAF, there were hyperautofluorescence. On angiography, early hyperfluorescence was seen with disruption of outer retinal layer on OCT and enlargement of blind spot, which was very much in favor of multiple evanescent white dot syndrome. Why secondary? Because one lesion which I showed you here on FFA, the third picture, sorry, here, maybe she had some previous episode of choroiditis, and now another point which was in favor of that was she had flu-like symptom preceding her vision loss. Maybe it was a case of secondary multiple evanescent white dot syndrome or epimude, you can say. Thank you.
Thank you so much, Dr. Asma. And now I request Dr. Ashish sir to share his 2 points on this.
Yeah, thank you, Dr. Asma, for highlighting a very rare case which we usually do not see so much in our clinics. But just a question, how do you differentiate between peak lesions and mute lesions?
So peak lesions, they are like in mutes, there can be interior interior segment interior chamber reaction can be there. Along with that, there can be some amount of vitritis can be seen, but
Any difference in the size of the lesions? Which
yes,
ones
sir.
are smaller than which ones are the bigger ones?
Mutes lesion, they are small punctate lesions are there.
Yeah, the mutes one
And
are.
peak lesions, they are mostly in the posterior periphery only, and they are very closely spaced. But mutes, the lesions are in the mid periphery, and they're not that much close as compared to the peak lesions. And
Yeah, but
that's
do mutes lesions they leave any scarring, or the peak lesions they leave any particular residual scar at the level of RP?
the peak lesions, they leave scar. Mutes usually don't.
Thank you so much.
Thank you, sir.
Thank you, Ashish sir. Now I request Dr. Muhammad Azam to share his perspectives on this case. Meanwhile, Dr. Asma, if you could stop screen sharing, please.
Yes, it is a very nice presentation. Thank you. Was there any recent change in vaccinations or anything in your patient?
Dr. Asma?
Sorry. Hi, yes, sir. Sorry, sir. Can you please repeat your question?
Yes, I asked maybe if there's any other changes in systemic, was there any history of vaccinations?
No, sir, there was no such history. She only said she had history of earache, that too 2 weeks prior to her symptoms.
Yeah, right. Okay. Thank you.
Thank you, sir. Thank you. We move on to the next presenter for today, Dr. Anjana R, presenting the Pandora's box.
Sir, can you hear me?
Yes, doctor. Please
Yes, sir.
share
So
your
I'll
screen.
share my screen. Hello, sir. Can I start presenting?
Please go full screen. Yes, please go ahead.
Yeah. So good evening, everyone. I am Dr. Anjana. I am going to present a case titled The Pandora Box. So the chief complaints are 81-year-old female. She came with complaints of sudden diminution of vision in the left eye for 1 week. There is history of diminution of vision in the right eye since childhood. She is a known case of hypertension controlled on medications. On examination, the corrected distance visual acuity is counting finger at 2 meters in the right eye and left eye had 6/18. IOP was within normal limits, pupil was normal, and anterior segment showed posterior subcapsular cataract. So moving on to the fundus picture, on right eye, we could see an optic disc pit along with a macular degeneration. Left eye, I'm sorry for the shadowing due to the PSC, we could see an intraretinal and subretinal hemorrhages along with left eye showing an occult optic disc pit that was captured on a multicolor fundus picture. We did a fundus autofluorescence that showed a central hypoautofluorescence suggestive of a resolved SRF, indicating a long-standing optic disc pit maculopathy. There was a peripheral ring of hyperautofluorescence suggestive of residual photoreceptor debris. Left eye showed a subretinal hemorrhage. We did an OCT. Right eye showed a macular schisis with complete outer retinal atrophy. And left eye, there was presence of subretinal fluid with hyperreflective foci. And the subfoveal choroidal thickness was normal for her age. We proceeded with an FFA and ICGA. Right eye, it showed a RP atrophy due to long-standing macular edema. And prominent choroidal vessels are seen in ICGA corresponding to the area of atrophy. And left eye, there was an indistinct leakage seen on FFA and correspondingly hotspots were seen on ICGA. So we came to a diagnosis of right eye optic disc maculopathy with chronic macular degeneration and left eye type 3 MNV with an occult optic disc pit. Right eye patient was advised regarding the visual prognosis and no intervention was carried out. Left eye, we did a PDT with intravitreal bevacizumab injection. On the first month after injection, the visual acuity improved, SRF decreased, but there was some persistence of SRF, so we advised a repeat Avastin injection. At 2 months, patient visual acuity improved and the fluid was completely resolved. The patient had a relapsing and remitting course and got multiple anti-VEGF injections and focal laser in the left eye. The focal laser was done with ICGA guidance. So on the last follow-up, the patient had a visual acuity of counting finger at 2 meters in right eye and 6/36 in left eye. So this is the Optos image of the last follow-up, which showed a right eye optic disc pit with a macular degeneration and left eye having a RP atrophy. And OCT through the lesion shows a submacular fibrogliotic scar. So what is occult optic disc pit? That is when we cannot see the pit clinically, but can be picked up in multimodal imaging like OCT, FFA, and infrared images. In our patient, we picked up through multicolor fundus picture. So, and these are the some important findings to see it through OCT if there's an intact membrane or defect in lamina cribrosa or FFA showing initial hypo followed by late staining. These are the stages of RAP as mentioned by Enosi et al. In his article. And these are the various management options. Anti-VEGF agents, the main therapy due to because increased VEGF expression by RAP lesion due to outer retinal hypoxia. Focal laser can also be tried for extrafoveal MNV. Surgical ablation is not currently used. Some few articles have reported. PDT not currently available. So coexistence of optic disc pit and type 3 MNV, a causative association or coincidental is still a question. Thank you.
Thank you, Dr. Anjana. And can we have Dr. Shreyas sir's opinion on this?
Yes, Dr. Anjana, it's actually very well like diagnosed and managed case. Actually, the findings were so subtle in the left eye. I should congratulate the entire team for making such a nice diagnosis. So I have two questions. So why did you what are the features which made you think of RAP? And the second question is that what is the role of PDT in this patient? We could have directly gone for anti-VEGF injections.
Yes, true. So the findings that suggestive of RAP is first thing, the choroidal thickness was normal for age, which was, so we thought something not just a neovascular AMD, but something additional to it. Secondly, in FFA, there was an indistinct leakage, and correspondingly in ICGA, there was hot spots because that ruled out other diagnoses like, CNV or PCV, which will, for example, in PCV, it will have polypoidal lesion, and clinically also we could see an orangish subretinal nodules. And then so these are the two things which we made. It's a RAP and not an other diagnosis. And
Did
also
you
the
have
outer retinal was normal.
Opta in the beginning?
Sorry, sir. Actually, the patient is in the follow-up for last 7 years, and the Opta mission has come up now. So that
Okay,
point of
fine.
time, we had ICGA, FFA, OCT, and all those things were done.
Okay, fine. So what about why PDT was given in this patient? Why not direct anti-VEGF?
Sir, because
Because even RAP
there
is
are
known
studies.
to respond very well to anti-VEGF injections.
True, sir, but
And in a one-night
it is
patient,
that.
I feel PDT would be little risky rather than just to start with anti-VEGFs.
True, sir, true. But this was done like almost 7 years ago. That time, PDT, combining PDT with an anti-VEGF agent was still an option. So we
Okay.
tried the best.
Anyways, the outcome was good. Congratulations.
Yes, sir. Thank you, sir. Thank you so much.
Thank you, Shreyas sir, for your inputs, and Dr. Anjana for the case. If you could kindly stop screen sharing. Next, I would like to invite Dr. Chandvi Dhawan, and Nawazi's ma'am will be the presiding judge. Dr. Chandvi, once she stopped screen sharing, I think we can start with yours.
Am I audible, sir?
Yes, Dr. Chandvi. Just a second, Dr. Anjana. Do
Sir,
you
I'm
please?
trying to stop the sharing. I closed it from my side, but I'm not sure why it's not.
Maybe
No,
I think you can override it.
Manjula ma'am, can you stop the screen share?
Okay, doctor.
Yeah.
Yes, Dr.
I
Chandvi,
think, is
please
it
go ahead.
done, sir?
Yes,
Yeah,
yes.
It's done. Yeah.
Yes, Dr. Chandvi, I think you're not audible.
Okay. Good evening, everyone. So I'll start with my topic, combined pulse cyclophosphamide and adalimumab therapy in a case of steroid-dependent recalcitrant ocular Behçet disease. So this case demonstrates a 1-year journey of a 16-year-old boy presented with bilateral panuveitis and macular edema in September 2024. After being treated erratically with on and off steroid therapy with past history of recurrent oral ulcer in last 3 years and positive pathology test and HLA-B51 raising suspicion of Behçet disease. Now on presentation, on the day of presentation, his fundus showed the vitreous haze with hyperemic disc and blurring of margin. And OCT showed shallow SRF, vitritis, and hyperreflective foci suggesting posterior segment inflammation. And similar findings were seen in left eye as well. And OCT was showing subfoveal ISOS disruption. Now, FFA was performed, which showed the classic diffuse fern pattern appearance. And FFA angiographic evidence showed Behçet disease. So we started him on pulse steroid for 3 days and followed by oral steroid starting with 60 mg. Now, after 3 months of being on oral steroid, he showed clinical remission in December. when he came to us in January, he showed relapse with the BRA, combined BRO and BRVO, and retinitis, perivascular retinitis patch, macular edema. So we started him on pulse steroid therapy, but we added pulse cyclophosphamide this time. And after that, we had to step up the Vicelon to 60 mg again, and we added azathioprine. And OCT showed worsened macular edema. Now, in March, he again showed relapse with the new tributary vein occlusion, but it was seen to be resolving following the pulse steroid and pulse cyclophosphamide therapy. Similarly, the left eye showed perivascular retinitis patch, which was also seen to be improving with pulse steroid and pulse cyclophosphamide. Now later, but despite being on the steroid two immunosuppressants and tapering steroids, he showed relapses. So we plan to shift him on biologic adalimumab, an anti-TNF inhibitor. So in June, we gave him the first dose of 40 mg adalimumab along with azathioprine, and later Vicelon 25 mg. In October, after being given 40 mg adalimumab bi-weekly for 2 months and monthly for 3 months, in October he was given his 7th dose of adalimumab, and we could achieve maintenance dose of oral steroid of 7.5 mg. Our next step would be to de-escalate the dose of adalimumab to 20 mg. So the pediatric ocular Behçet disease can be a steroid dependent and resistant to conventional immunosuppressive therapy. Combined therapy with pulse cyclophosphamide and adalimumab can be a good combination for achieving durable remission. This case demonstrates that combining pulse cyclophosphamide with biological therapy is both safe, effective, and well tolerated in recalcitrant case of pediatric ocular Behçet. Thank you.
Thank you, Dr. Chandvi, for the wonderful case. Now I request Dr. Isha Acharya to share her perspectives on this, followed by Namazi's ma'am, any questions?
Very nice case. And since you have told everything regarding what's the use of oral steroids along with the different immunomodulator therapy and how the role comes out when there is a refractory status and when there is like different sorts of recurrence and different sorts of manifestation that this patient was coming with. So very nice
Ma'am.
documentation. It was an excellent case. I
Yes,
just
ma'am. Our
asked that.
main goal is to yes,
Yes.
ma'am.
So what was your like, how did you decide the best choice of IMT, the immunomodulator therapy that you gave?
So, ma'am, because of he being a pediatric, we thought we didn't want to include many immunosuppression, and azathioprine has lesser side effects compared to the methotrexate and adalimumab. Azathioprine is preferred and in the pediatric cases for ocular Behçet's, whereas methotrexate is preferred, but not. It is a choice for Behçet's disease. So azathioprine was the choice, and we needed cyclophosphamide for the immediate remission of the relapses that he showed. So we added cyclophosphamide, but after that we needed to maintain the remission. We achieved the remission with cyclophosphamide, but to maintain that remission, we added adalimumab.
Great
And
case.
the goal was we started the loading dose with 40 mg. Ideally, it is 80 mg. So cyclophosphamide helped us to reduce the dose of the adalimumab.
Okay, great case. Congratulations for this.
Thank you.
So Dr. Chandvi, if I could just ask you, what was the weight of the patient?
Ma'am, 74 kg. He's a well built.
Okay, and what was the dose of azathioprine that was being prescribed?
Ma'am, 50 mg TDS, 150.
Around 150. Additionally, although adalimumab loading therapy can be 80 mg, we do not increase it beyond 1 monthly. We don't give it at 1 monthly intervals. So it can be loaded at 80 mg.
We started
keep
with
it at
2
40
weeks.
for 2 weekly intervals. There is no
Yes,
point of increasing the intervals at 1 monthly interval. Secondly,
after 2 months we did.
Yeah, so it
Uh,
does not work like that way. So if you
no,
just stop
we gave
Humira,
bi-weekly for 2 months. Bi-weekly for 2 months. Then after that, we
so
shifted to monthly.
the efficacy of biologicals is unlike the other immunomodulators in which we modify the doses. For biologicals, it's 40 mg, 2 weekly intervals, and that would continue. We would not increase either the interval or reduce the dose for biologicals. Secondly, would you consider JAK-STAT inhibitors in such cases who have been started on azathioprine, cyclophosphamide, as well as a biological? Would you consider a JAK-STAT inhibitor in such cases?
We might, but I'm not studied much about.
Okay, so unlike a biological such as adalimumab, which is focusing on one part of the inflammatory cascade, that is anti-TNF alpha, JAK-STAT inhibitors inhibit overall inflammatory cascade. So they may work better in refractory cases as well. Thank you.
Okay,
Well
ma'am.
presented.
Thank you. Thank you for your input, ma'am. Thank you.
Can we move ahead to the Dr. Nishi Prasad? Can you present your case?
She was.
She's back. She's back.
She's back. Yeah.
Yeah, you can go ahead with your case, doctor, and presiding judge.
Just kindly note this presenter is on the 16th.
Yeah, Dr. Shre. The presenter is on 16th on the live sheet, judges. So kindly note above Neelam Kumari and kindly note. Yeah, you can start your presentation, doctor. No, you can show that from the title slide. Karthik, you can reset the timer.
Sir, I'll share it again.
Done, sir.
Yeah, no issues, doctor. Please go ahead. Yeah, you can start, doctor. Slideshow start.
Problem in moving the slides.
Doctor, you're pressing too many buttons at a time. So my request to you would be is go press a button, see the reaction, and then that would be better. Because you'll have an initial lag once you start sharing.
Is this visible, sir?
Yeah. Go a bit slow.
Yes. A tale of retinopathy, unmasking the presenting feature of SLE. So this was a young female who was apparently asymptomatic 5 days back when she developed profound diminution of vision in her both eyes, which gradually increased over 5 days. But I'm not able to see is my slideshare visible?
Yeah, slides.
Yes, doctor. Yes, please. Just press on the screen and use arrow keys to move between slides. Just press on your slide. Just click on your slide. Okay. Now the screen sharing is stopped.
What the problem is, it's not moving and then suddenly it stopped.
No, don't keep pressing the keys because it'll end the slideshow and close. So just take it slow. Go full screen, please.
Can I do from beginning, sir? Can I start from beginning?
Yeah, okay.
Okay, so this was a young female who was
No.
apparently.
Doctor, yes, just hold a minute. Just now your screen is visible. It's on the second slide.
Yes.
You can continue. Yeah.
Yes. Who was a young female who was apparently asymptomatic 5 days back when she developed profound diminution of vision in her both eyes, which gradually increased over 5 days. There was also a history of rashes in her both shins and also occasional joint pain. No history of trauma or any redness, discharge, floaters, no other systemic comorbidities. Her best corrected visual acuity in right eye was 560 and left eye 660. Anterior segment was completely within normal limit. Posterior segment in her both eyes, disc was normal. And a macula, there was multiple cotton wool spots located along the vessels reaching up to the fovea, and there was retinal thickening suggestive of macular edema. Also, the multiple cotton wool spots were noted all along the vessels, and multiple areas of retinal whitening suggestive of ischemia were noted in her both eyes. General physical examination, vitals was normal, pallor was present, there was few after ulcers in oral cavity and diffuse purpuric rashes over her shins and dorsum of hands. Right eye, there was cystoid macular edema, significant with retinal ischemia. Also in left eye, there was significant cystoid macular edema. And this ischemia was gradually increasing over visit day 1 to 8 to 10. FFA revealed patchy choroidal filling with multiple non-perfusing arterioles and enlarged foveal avascular zone suggestive of macular ischemia. Few microaneurysms were present. Her blood investigation revealed positive for anemia, leukopenia, positive anti-nuclear antibody and anti-double-stranded DNA antibody, and negative for other factors. So this was a follow-up after a month in which FFA revealed patchy choroidal and patient was given IV methylprednisolone 1 gram for 5 days, followed by oral Visalone for 1 milligram per kg body weight in a tapering manner. And intravitreal anti-VEGF injection was given right eye followed by left eye, and rheumatology referral for SLE, and from where a patient was started on rituximab, cyclophosphamide, mycophenolate mofetil, and sectoral lasers were done periphery for the NVs. So SLE retinopathy is the most common posterior segment finding in patients with SLE, where most common findings being cotton wool spots, phlebitis, arteritis, occlusions, vascular tortuosity, narrowing, microaneurysm, and retinal edema. Although not in the criteria for diagnosis, SLE retinopathy can sometimes be the presenting features of lupus in about 1/3 of the patients. Hence, always we should keep SLE in the differentials while looking at the vascular pathology, especially in the young people. That's all from my side, sir.
Thank you, Dr. Nishi, for the nice presentation. Dr. Shreyas, sir, your inputs, please.
Yeah, Dr. Nishi, that was well documented case and well managed also. So I just have few questions here. Actually, the initial presentation was very classical of a Purchar-like retinopathy. So
Yes, sir.
yeah, so what differentials did you have? Like considering the age of the patient, one would directly consider
Yes,
probably
sir.
thinking
So
of
there was
SLE.
no history of traumas. So there was no history of any trauma or any fracture or any surgery. There was no symptoms pertaining to any acute pancreatitis. We had kept the differentials as acute pancreatitis, rickettsia, and other causes like pre-eclamptic. She was not a pre-eclamptic patient also. So we had to go for the connective tissue disorder. So we investigated for the blood tests.
Okay, fine. Thank you.
Thank you, sir. Can we move on to the next presenter, Dr. Nishi? Could you please stop sharing screen? Yeah, thank you. Yes.
Dr. Krunal.
Dr. Krunal Manwar, are you there with us?
Yeah, can you unmute yourself? Yeah.
Yes, doctor. Dr. Krunal will be presenting next, and Dr. Ashish will be the presiding judge. Over to you, Dr. Krunal. Please start your screen sharing.
So I think the screen is being shared, I think.
Yes, you need to go full screen, please.
Sure. Is it okay now, I think?
Yeah, please start.
Okay. Good evening, everyone. So I'll be presenting a case on surgical removal of a large intraocular foreign body from a posterior chamber. So, 30-year-old male patient was presented to us with sudden onset diminution of vision following a alleged history of trauma with a metallic foreign body while working. So, by profession, he was an electrical wire worker. And in the right eye, and the clinical picture, we see that there was a large, thick metallic wire penetrating the cornea and iris, and its superior part. And there was the AC was shallow and IFEMA was present, and the vision was hand movement close to face, and the wire was penetrating. And the diagnosis of penetrating injury with a large intraocular foreign body was made, and from that, we did a pre-op imaging of NCCT head and orbit was done, and a hyperdense metallic foreign body extending from the cornea through and through the orbit up till the posterior pole was seen. So the trajectory was anticipated that the foreign body is penetrating cornea, lens, retina, and it is going through and through the retina. But fortunately, the optic disc was not directly involved, and the foreign body was located superior temporal to the optic disc. Again, we planned the surgery as a primary surgery. We did primary IOF removal, intraocular foreign body removal, along with marginal tear repair. So before that, we did a pre-operative preparation with tetanus prophylaxis and general anesthesia, along with the neurosurgery consultation or neurosurgery help was seek, because the wire was penetrating all through the globe, and we didn't know if the hemostasis will be achieved or not during the OT. So this is how the foreign body was removed. So the whole foreign body en bloc was removed from the cornea, from the orbit, and external approach was taken. Fortunately, the hemostasis was achieved on its own. There was no internal bleeding also. So on the post-operative day one, the visual acuity was hand movement close to face, and as anticipated, the globe was soft, hypotonus with IOP of 7 mmHg and a mild anterior segment inflammation. With the mid-dilated pupil, we could see the fundus, the media was haze, and the dispersed vitreous hemorrhage was visible. So the decision was taken not to go for any posterior segment exploration initially while the globe is being formed. After the 2 week after the 2 week follow-up visit, there was the corneal wound was well opposed, and the sutures were well formed and healthy. And after the systemic topical antibiotics and systemic steroids and topical steroids, the patient presented with us with the vitreous haze, which was increasing, and we did a USTB scan, which was suggestive of vitreous exudates. So the provisional diagnosis of this endophthalmitis was made, and we did gave 3 intravitreal antibiotic injections every alternate day, and the hypertony was managed after each injection with systemic steroids. And fortunately, the vitreous exudates were relieved, and after again 2 weeks of follow-up, we planned for a vitreoretinal surgery in which the lens was removed, lens aspiration was done, and along with it, we did Pascal vitrectomy around the foreign body, and a fibrous stump of this in the posterior segment. There is a fibrous stump was present, which was removed using the vitrectomy cutter. And after doing the vitrectomy, silicone oil tamponade was also done.
Doctor, I think you've really exceeded the time, so you can just finish your presentation.
Sure.
No, just go wrap it up in 10 more seconds.
Sure. It stopped, I think.
Oh, they only stopped it. You can just finish up. Give your finishing comments, doctor. No issues.
Okay, sir. So basically then there was on the follow-up visit there was siderosis, the retina was well attached, and otherwise the vision after the post-op vision was 4-meter finger count, and again the retina was well attached. Silicone oil was tamponade was done, and after that siderosis developed, and for that. As of now, silicone oil removal was planned after that, and the vision at last is 5/60 as of now for the patient. That's it from my side, sir.
Thank you, doctor. Now we'll move on to the judge, Dr. Ashish Markan.
Yeah, thank you, Dr. Kunal. I think that was a very interesting case. And what was the length of the intraocular foreign body? The total length of the wire?
So it was exceeding 5 centimeter. It was more than 5 centimeter.
So it was impacted in the supratemporal quadrant, you said, initially to begin with.
Sir, yes, sir. Yes, sir. On the NCCT, we found out that it was penetrating all the way through the globe, and it was coming out superior temporal to the optic disc.
But then did you remove it blindly from the anterior root without taking care of the posterior part?
So that's yes, sir. So we did it along with neurosurgery help that if we could not achieve any hemostasis while doing that, while removal of that IOFB, we
But
will need that.
how did you make sure that it would not bleed? Because the video which you showed us, you just removed the foreign body from the cornea, and probably you just sutured the corneal site, and then you basically left the patient for 2 weeks, and then at that time the patient developed endophthalmitis, I believe.
Yes, sir.
But I feel like if the foreign body was eccentric and your foreign body was not directly into the cornea, you had a good view. Probably once you removed the foreign body, when you knew that there was an impacted site at the posterior pole, I think you were lucky enough that your patient at the end of the day has a vision of 5/60. But probably I would have managed it slightly differently. First thing is that once I removed the foreign body blindly, I would not have done that to remove it very blindly. I would have actually made the ports, removed it from the interior part, made sure that if it bled, I would have done a vitrectomy, made sure that I could actually cauterize and stop the bleeding. Because, see, in your case, the retinal detachment did not happen. But you never know if once you remove that foreign body from that side, it could have bled, the bleed could have gone subfoveal, or there could have been a posterior perforation which happened. And probably you could have also prevented the endophthalmitis. Because waiting for 2 weeks and then basically your eye was hypotenuse, probably with the intravitreals, maybe then the infective load was not that much that your endophthalmitis also resolved. I think both the surgeon as well as the patient, they have been lucky enough in this case, but I would have managed it slightly differently. But otherwise, well documented case. Thank you so much.
Thank you, sir.
Yeah, for the next case, we have Dr. K. Janani.
Yes, sir.
Yeah, your presentation on Through the Looking Glass, Unmasking Sarcoidosis. You can go ahead, doctor. The presiding judge would be Dr. Nawaz, ma'am. You
Evening.
can start. Your slides are visible, doctor. You can start.
Okay, sir. Good evening. Today I'm going to present on the topic Through the Looking Glass Unmasking Sarcoidosis in the Eye. Sarcoidosis is a multi-system disease of unknown etiology. It is also characterized by the formation of granulomas in various organs, most commonly affecting the lungs and lymph nodes. But ocular involvement is well recognized and may occasionally be the initial manifestations. Any part of the eye and its adnexal tissues can be involved, and mostly uveitis and optic neuropathy are the main manifestations which may require systemic treatment. The chief complaint was a 23-year-old male complained of diminution of vision in both the eyes since 1 week. And On the presenting his illness, he was apparently asymptomatic 1 week back, after which he developed diminution of vision in both the eye, which was insidious in onset, and it was associated with redness, increased sensitivity to light, and mild pain. He was mechanic by occupation, and he had no history of any discharge, matting of lashes, watering, colored halos, floaters, flashing of light, trauma, and ocular surgery. No history of cough, chronic cough with expectoration, evening rise of temperature and weight loss, and no history of any skin lesions or recurrent mucosal and genital ulcers, no history of contact with pets, migratory joint pain, back pain, and stiffness. So family history was not significant, and personal history was normal. General and systemic examinations were within normal limits. On ocular examination, the patient's vision was 636 with pinhole, 624 in both the eyes, and the intraocular pressure was 18 in the right eye and 16 in the left eye. He had a conjunctival circumcorneal condition in both the eyes, and in the cornea had few white, small, round deposits over the corneal endothelium and suggestive of KPs. And the anterior chamber showed cells 2+ and flare 2+ in both the eyes. Iris showed multiple nodules seen over the stroma of the iris away from the pupillary margin, and it is suggestive of Busaka nodules. Other details were within normal limits. This is the image showing the Busaka nodules. And this is a diagrammatic representation of KPs and circumciliary congestion Busaka nodules. On fundus examination, the media showed vitritis and vitreous haze 1+ in both the eyes. Discan vessels were normal. Macula foveal reflex was present. Background was normal, and the peripheral retina, left eye, we noted few faint white lesions present at the inferior periphery, suggestive of snowballs. This is the diagrammatic representation. And on investigations, we found to be CRP was found to be elevated, and angiotensin converting enzyme was also elevated. The other reports were within normal limits. So the diagnosis would be both acute granulomatous panuveitis, and according to the International Workshop of Ocular Sarcoidosis criteria, it is probable ocular sarcoidosis. On managing, the patient was started with both eye prednisolone 1% eye drop hourly and hometropin 1% eye drop BD was given, and physician opinion was obtained, and they started on oral tablet 40 mg OD for 10 days, and the patient was asked to come for review after 10 days. So the conclusion is, in this case, it emphasizes the significance of considering the systemic conditions in ocular presentation also. So because early identification, treatment, and systemic evaluation are very crucial for preventing irreversible ocular morbidity and detecting the systemic diseases. Thank you.
Very well on time, Doctor. You're a really great presentation, Doctor. The presiding judge would be Dr. Nawasi. Madam, can you please ask your questions?
I just have one single question. What would your differentials be for the patient presenting with granulomatous uveitis, anterior uveitis?
Ma'am, initially we must rule out tuberculosis because it India. Hello?
You're
Ma'am, am I
audible.
audible?
Yeah,
You're
you're
audible,
audible.
you're
You're
audible.
audible, doctor. No, you are not.
Dr. Janani, you're audible. You can go ahead. Please answer the question.
Yeah, so the first differential we must consider tuberculosis because it is very common, and the other diagnosis we can think of are like even sarcoidosis, then syphilis, then syphilis also, herpes also, but the TB and herpes and other leprosy and syphilis were negative, investigations were negative. So we came to a conclusion that it could be sarcoidosis because of the elevated ACE levels.
Okay.
Dr. Pranesh, I have a comment.
Yes, sir. Please, you can ask, sir. Please.
Yeah. Dr. Janani, you showed a picture of a hand showing a tattoo. I was
Yes,
just curious, you wanted to show the man-to reaction there or wanted to highlight the tattoo there?
No, sir, no, sir. It was the man-to reaction. The patient
No,
had the
because
tattoo.
why this is because there
Yeah,
are
yeah.
case reports of tattoo which can lead to sarcoidosis. So
Yes, sir.
there are reports of tattoo-induced sarcoidosis and sarcoid uveitis also.
Yes, sir. Yes, sir. But
Did you ask the patient why when was that tattooing done?
it was probably 1 or 2 years back, sir. He didn't exactly mention the year.
because it was
Not
not
preceding this event.
No, sir. No.
Okay, so if it was recent event of tattooing, no, so that can be kept as a differential. Like tattoo-induced sarcoidosis is one possibility.
Okay, sir.
Okay, thank you.
Thank you, sir.
Can we have a final comment from our expert panel, Dr. Isha? Dr. Isha, sir.
I think she's not the Dr. Ganesh. Okay, I think.
Okay, no issues. I'm handing over to Dr. Niranjan for the sponsor video. Niranjan, you can take over. Thank you very much.
Thank you, Pranesh sir. So it is indeed my pleasure to be sharing the promo video of our premium sponsor, Neomedics, who was kind enough to sponsor this initiative of Naadi 3.0 International. So I request Doctor to kindly stop screen sharing, please.
Yes,
Dr.
sir.
Janani.
Yes, sir. Yes, sir.
So for all those who joined us today, so Neomedics is sponsoring the event of Naadi. And
Manjula, can you switch on, close this?
yes, sir. Yes, sir. Yes. So this video does not have any audio to it, so you don't have to look for any glitch or anything of any sort. So this is meant to show the entire range of their products. Just give me a minute. There you go. So they have a wide range of products addressing the various requirements of every ophthalmologist.
Actually, these preservative-free drugs are very useful in patients who have very allergy to preservatives. So they have wide range of preservative-free products.
So these are some of their products in the pipeline. Once again, thank you, Neomedics, for supporting this initiative. Over to Pranay sir for the rest of the proceedings.
Niranjan for the short intro about our sponsor. Very kind of them to sponsor this whole event. We're really grateful to them. Now, next, moving on to the next presenter, Dr. Kondru Roshita Gagarin on a presentation on CRAO. The presiding judge would be Dr. Shreyas, sir.
Dr. Kondru?
Yes, sir. Yes, sir.
Yeah.
Is it visible, sir?
Yes, doctor, visible.
Good evening, everyone. Today I'm going to present a case from
Can you
ischemia to
start the time,
intervention.
please?
Sir,
Yeah, I'll do that. No issues. You can go ahead, doctor. You can go ahead. I'll take care of it.
good evening, everyone. Today I'm going to present a case from ischemia to intervention, a closer look at CRAO. A 35-year-old female presented to the OPD with diminution of vision in the left eye at 5 p.m. the previous day, that is 18 hours after the symptom onset. She had no history of ocular trauma, no history of headache, jaw claudication, or any other specific ocular complaints. Past history, she gave a history of decreased hemoglobin before 10 years during her pregnancy, for which she was under medication stopped on her own. No history of any ocular surgeries, and there is no history of any systemic illness. General physical examination, Pale noted on examination of palpebral conjunctiva, rest of within normal limits. Coming to the ocular parameters, right eye vision was 6/9 with pinhole improving to 6 with near vision N6. Intraocular pressure was 16 mmHg and color vision was normal. Coming to the left eye, distant vision was 1/60 with pinhole at no improvement. Near vision couldn't be assessed. Intraocular pressure was 16 mmHg. Color vision was defective. Right eye anterior segment findings were unremarkable, whereas left eye pupil showed RAPD and rest were within normal limits. Coming to the dilated fundus examination, right eye findings were within normal limits, whereas the left eye showed media. Media showed pale retina at the posterior pole with disc hyperemic disc with the margins well defined. Cup disc ratio of 0.3:1. Vessels tortuosity is seen and macula. We can able to see cherry red spot at the macula. This is the fundus image of the right and left eye. Right eye is within the normal limits, whereas the left eye showed cherry red spot at the macula and the tortuosity of the vessels seen with the hyperemic disc. Coming to the management, immediate ocular massage and the DAISY paracensis were done under aseptic precautions. Stat tablet estazolmide 500 mg was given. Anti-inflammatory and antibiotic eye drops were started. Investigations from our ocular side, we have advised OCT macula. Systemic investigations revealed HbO of 6.1 gram per deciliter. ESR is raised to 25 mm per hour. The rest CRP, urine routine, homocysteine, RBS were within normal limits. Coagulation profile was normal. ECG and echo were normal. Peripheral smear revealed severe microcytic hypochromic anemia diagnosed as iron deficiency anemia with raised transferrin of 450 mg per deciliter and low ferritin of 2.94 mg per ml. Radiological investigations, carotid and vertebral Doppler was normal, whereas ultrasound sonography of the orbit showed complete occlusion of the left central retinal artery. This is the image showing complete occlusion of the left central retinal artery. Medicine opinion was obtained in view of the anemia, and 1 unit of packed RBC was transferred, and the patient was discharged. On first follow-up, which he reviewed 1 week later with left eye OCT macula, vision remained the same and HB was raised from 6.1 to 8.4. Now OCT macula showed the macular edema for which anti-VEGF and intravitreal anti-VEGF injections were planned, and but patient wasn't willing. Now this is the fundus image of the left eye, which showing the disc edema with dilated and tortuosity of the vessels. On second follow-up, which was 2 weeks later, vision and color vision remained the same, and fundus showed the pale disc sized of consecutive optic atrophy. Coming to the diagnosis, left eye consecutive optic atrophy due to the non-arthritic CRAO secondary to the chronic anemia. These are the articles related to the CRAO and with sickle cell disease and beta thalassemia. My take-home message will be: this report presents a rare case of CRAO in young female with no known comorbidities. In this case, the chronic anemia may have been a contributory factor, though not a proven cause of occlusion. Limited evidence exists for direct link of iron deficiency anemia to cause vascular occlusions, warranting further research and studies. Early recognition, prompt management, and evaluation for underlying systemic disorders are crucial. Thank you.
Yeah, nice, Doctor. Well on time. Yeah.
Dr. Shreyas sir will ask the question to
Dr.
the
Roshita, can we have your go back to your presentation and can we have the first fundus picture?
Yeah, sure, sir.
Okay. You're able to.
Sir, this is the first fundus image, sir.
Okay. So what was the visual improvement later? Like how much did the patient improve to? Like
actually, unfortunately, there is no visual improvement, sir. It remained the same for after second follow-up also, sir. It's been 1/60.
Why the patient after the initial presentation, we can actually see progression to some retinal hemorrhages, peripapillary retinal hemorrhages and all. So what do you think is the possible course in this patient? And actually doesn't look like a typical CRO. For me, it looks more of PAM lesions. So do you have the OCT at this point of time?
No, sir. We have advised, and she at the time, unfortunately, she was not ready for that investigation, sir.
Yeah, can we go on to further slides, which is showing that peripapillary retinal hemorrhages?
Yeah, sure, sir.
So how do you explain that this picture? Now we have the disc edema and some hemorrhages can be seen.
Yes, sir. Yes, sir. This is a picture showing the somewhat combination of both the venular and retinal CRVO picture also, sir. Patient might have developed later.
So what I would feel is it was not probably a typical case of CRVO in the beginning.
CRVO.
And
Yes,
anemia
sir.
usually leads to a CRVO kind of picture rather than a CRAO. So I don't find even any risk factors which have contributed for CRAO in this patient, particular patient. And actually seeing the evolution, it has probably gone into CRVO kind of appearance.
Picture.
Yeah.
Yes, sir.
So
And based on first fundus image, and we have diagnosed proper diagnosis like based on this cherry red spot and that
no, rather
pale
I would
retina
say
at the posterior pole, we
to
have
label it
diagnosed
as
as SCR.
PAM lesions with
Okay.
even the veins are engorged in that initial
Yes,
presentation
sir.
itself.
Yes, sir.
So it is not only arterial occlusion, some actually venous
Then
stasis which has progressed
okay,
further.
sir.
So that is what I
Okay,
feel.
sir.
Okay.
Okay.
Anyways, thank you.
Sir. Thank you, sir.
Thank you, Dr. Rashita. You can stop your screen sharing. We'll go to the
Yeah,
next
sir, sure, sir.
participant, Dr. Utkarsh Rodke, for his presentation on multifocal placar pigment epithelium, AMPI.
Am I visible, sir?
Yeah, you're visible. You can share your slides, doctor. Your slides are visible. Go ahead, doctor. All the best.
Good evening, everyone. Myself, Dr. Utkarsh Rudki from Command Hospital, is going to present the topic. A 18-year-old girl was apparently asymptomatic 3 days ago when she
Doctor,
started.
one second. You're not on slideshow.
My slideshow is not visible, sir. Is it visible now, sir?
No, Dr. Utkarsh. It's still showing your slide deck, not the slideshow.
1 second, sir.
You're using WPS, is it? Okay. Can you go to the first slide and then can you start from the current slide? Yeah. From the beginning, yes. Perfect. Yeah. You can start now, doctor.
I'm presenting a case of 18-year-old girl who was apparently asymptomatic 3 days ago when she started experiencing blurring of vision in the left eye more than right eye, which was sudden in onset, progressive and painless, associated with distortion of objects. It was not associated with redness, watering, or photophobia. There was no significant negative history present. On past ophthalmic history, there was history of spectacle use since 1 year. Past medical, family, and allergic history was within normal limits. General physical examination was within normal limits. Ocular examination revealed head posture to be central. Ocular alignment was maintained. Ocular movements were full, free, and painless in all gazes and direction in both the eyes. So the best corrective visual acuity was 6/9 in both the eyes with intraocular pressure of 12 mm Hg and 14 mm Hg respectively. Anterior segment examination of the right eye and the left eye was within normal limits. There were no signs of any inflammation cells. The posterior segment examination of the right eye revealed multiple exudative retinal detachment shown in the in the red arrows and multiple several yellowish placoid lesions which were present at the posterior pole shown here in the red arrows. Similarly, in the other eye also, we can see there are multiple dome-shaped elevation at the posterior pole and multiple yellowish placoid lesions shown in the red arrows. So the differential diagnoses were VKH syndrome, APMPP, multifocal serous chorioretinopathy, or syphilis. So on the OCT macula right eye, the EDI OCT showed multiple areas of serous retinal detachment red arrows along with bacillary layer detachment involving the fovea shown in the yellow arrows. There were also evidence of mildly increased choroidal thickness in both the eyes. Similar finding can be seen in the left eye also. So the FFA was done, which revealed hyperfluorescent lesion in the early phases, which increased in intensity in the eye. In the late phases, we can also see there is pooling of the dye in the serous retinal detachment areas. Similar findings were also seen in the left eye of the patient. So the ICG was done, which showed hyposenescent lesion in the early phases, which became more hyposenescent in the late phases of the ICG. Similar findings were seen in the left eye also. These are the blood investigations done for the patient. The Montu test was positive in this patient. So the chest X-ray and NCCT was done, which came out to be within normal limits. So in the presence of multiple yellowish dot lesion in the posterior pole, multiple exudative detachment, bacillary layer detachment, hyposenescent lesion in the posterior pole on ICG, and no RP undulation, the diagnosis of APMPP with exudative detachment and bacillary detachment both high was made. So on observation, no oral steroid or IV steroids were given. Observation only was done. So in view of CNS involvement in APMPP, neurologist opinion was sought out. There was no sign or symptom suggestive of any neurological involvement. MRI and MRA brain was within normal limits. These are the serial follow-up photo of the right eye of the patient over 1 week. As you can see in the follow-up photos, the serous retinal detachment is decreasing day by day. And in the left eye also, the serous retinal detachment is decreasing over the past 1 week. The yellowish lesions are also decreasing in intensity and the size in both the eyes. This is the serial OCT. As we can see in the serious OCT, there is decrease in the SRF over the past 7 days. After 2 weeks, the best corrective visual acuity of both the eyes was within normal limit and the OCT was within normal limit. So we did literature review where only 2 to 3 cases of the APMPP showed bacillary layer detachment. These are those cases. So the take-home message is multimodal imaging is essential for accurate diagnosis of APMPP. Bacillary layer detachment can be seen on OCT in active lesions. The disease is self-limiting. Corticosteroid should be reserved for recurrent, severe, and CNS involvement involving cases only, and early recognition prevents unnecessary investigation and therapy. Thank you.
Thank you, Doctor. We'd like to get a closing comment from our judge, Dr. Ashish Markan.
Yeah. Thank you, Dr. Utkarsh, for this wonderful case. I think you brought up this case, and it is very important for everybody of us to actually realize the difference between VKH and APMPP. You clearly showed that all these exudative detachment, they resolved within a week. So basically, APMPP is a self-limiting disease, whereas VKH would require a long-term immunosuppressive therapies because they have a tendency to recur. Just a quick question for you. At what level is the bacillary layer detachment happens?
So bacillary layer detachment is at the level of the myoid zone of the rods and cones, sir, the inner segment.
Okay, so it is basically split in the myoid zone, and it basically shows an acute activity which is happening, probably an inflammatory activity. It could be seen in VKH. So basically, many of us can get confused at an initial presentation and can misdiagnose it as VKH also. But what are the pointers which were against VKH in your case?
Sir, taking from the history, there was no tinnitus, no headache, or no viral prodromal symptoms present in the patient. Secondly, if the VKH was there, the serous retinal detachment would not be limited to the posterior pole, only it will be present in the periphery also. And the way there was no vitritis in the patient, no optic disc edema, and moreover, the patient resolved very early. And the second day only we can see the resolution of the symptoms in which the VKH will not be there. And in OCT also, were no RP undulations which are present in the VKH, sir. The choroidal
So you
thickness is
see,
also more in the VKH, sir.
so the point here is that even despite there are no systemic features, you can have an ocular Harada disease. But yeah, your patient did not have disc edema. There were no vitritis or vitreous cells. Thirdly, the choroidal granulomas in VKH are actually full thickness choroidal granulomas, which are hypo to begin with, and they remain hypo on ICG. And because they're full thickness choroidal granulomas, they will have this RP undulation, which usually is seen in all these patients of VKH. And as soon as you start them on pulse steroids or on a high dose oral steroids, the RP tends to flatten out because these granulomas tend to resolve. So I think very beautifully put up case. Congratulations to the authors and the team. Thank you so much.
Thank you, Dr. Utkarsh. Now we will go on to the next presenter, Dr. Kavya Satanahalli, on a presentation on ARICANET. Doctor, can we have your presentation? You can exit, Dr. Utkarsh.
Hello, am I audible, sir?
You're perfectly
Am I
audible.
audible, sir?
Yes, yes, yes.
Is my slides visible?
Yeah, you can start, doctor. All the best.
Okay, thank you. I'll be presenting a case where a tiny nut with a big injury risk. A 50-year-old male patient presented to our OPD after areca nut fall over left eye during harvesting 2 months back. He complains of gradual diminution of vision in left eye associated with pain, redness, watering, and photophobia. There was no history of flashes of light, no history of similar complaints in the past. Past history was not significant, family history was not significant, personal history was within normal limits. On general physical examination, a 50-year-old male was moderately built and nourished, well oriented to time, place, and person. The other pallor icterus was absent. On ocular examination, head posture was normal, facial symmetry symmetrical, and ocular posture orthophoric. On right eye examination, distant vision was noted to be 6 parts. On pinhole improvement, it improved to 6, and near vision N12. Extraocular movements was free and full in all directions. Anterior segment was within normal limits, and IOP was 16 mmHg. On left eye examination, the unaided vision was 624 parts. with pinhole improvement to be 618 parts and near vision N36. Extraocular movements were free and full in all directions. Lid was normal. The conjunctiva circumciliary congestion was noted. Sclera and cornea was normal. On anterior chamber examination, according to Von Erich's grading, it was grade 3 with AC2 plus cells present, and vitreous blob was present in the AC with iris pigments as shown in the picture and the diagrammatic representation. Iris, it was brown and irregular edges at the pupillary margins at 6 to 8 o'clock position was noted. Pupil, it was 6 mm mid-dilated pupil, vertically oval, with sphincter tear noted at 6 and 8 o'clock position. Then the direct and indirect reflex was absent. Lens, there was a subluxation noted with zonular dialysis from 6 to 10 o'clock position. The NS1 with minimal PSC noted. IOP was 20 mm Hg. On fundus examination, right eye, media was clear, disc, vessels, and macula was within normal limits. On left eye, the media was clear with no vitritis noted. Disc was within normal limits. Vessels were arising from center of the disc with dichotomously branching, and macula was within normal limits. The diagnosis was right eye was within normal limits. Left eye, there was a closed lobe injury according to ocular trauma score 4 with subluxated cataract and 4 clock hours of zonular dialysis with traumatic mydriasis. The surgical management was planned after the preoperative evaluation. There was a left eye pars plana lensectomy with anterior vitrectomy done with iris claw implantation with pupilloplasty under local anesthesia under guarded vision prognosis. On post-op 1 month, the unaided vision was 612 with the pinhole improvement to be 6 parts, and cornea was clear. AC was well formed and there was no cells noted. Iris claw was enclaved at 6 and 9 o'clock position, and the fundus was found to be normal. In conclusion, the areca nut fall injury to eye is a significant cause of closed lobe injury in Malnad region, that's the Western Ghats, and can be promptly treated with early surgical intervention to provide good outcomes. Awareness about areca nut farmers and protection gear, such as protective goggles, will prevent this injury. Thank you.
Well on time, Doctor. Great presentation. Can we have our preceding judge, Dr. Nawazi Sheikh, ma'am, to ask a question to the
So
contestant?
I have one question and one comment. So my question is, besides the clinical features that you saw in your patient, could you possibly elaborate some fundus changes that could occur following blunt trauma in a patient?
There can be retinal tears noted, ma'am, and there might be retinal dialysis also, and hemorrhages also can be noted due to blunt trauma.
So they could also have post-traumatic full thickness macular hole. So for my comment, so you
Yes.
said 4 clock hours of zonular dialysis, and you went ahead
Yes,
with a pars plana lensectomy with an anterior vitrectomy. What about considering for say back fixation? Because using a posterior enclaved iris claw in a patient who already has traumatic mydriasis, you did have to do a pupilloplasty as well. And already the patient might be prone to develop a retinal detachment in such cases. So I would have probably preferred back fixation in such cases, but well managed. Congratulations.
Thank you, ma'am. Thank you, ma'am.
Hello? Yeah. Can we go on to the next presenter? Dr. Divya T.
Stop sharing, yeah.
Yeah, Dr. Divya T. The presiding judge would be Dr. Shreyas, sir. Dr. Divya? Our topic is on ocular manifestations of keratoconus fistula. Dr. Divya?
I don't see.
Or in the participant list, right?
No, Pranesh. No,
Yeah, okay, fine. We'll move on to the next participant, Dr. Akanksha Waldia. Her case presentation on ARN.
Yes, sir. Is my screen visible, sir?
No, not yet. Yes. Go to the slideshow, Dr. Akansha. Perfect. Can start.
There is a tab, sir. That's
What happened?
no, it's good. Okay, good evening. So today I'm going to be talking about a case of acute retinal necrosis and how we managed it. So our patient was a 47-year-old male patient who presented to OPD with chief complaints of floaters and blurring of vision in his right eye since 15 days, which was associated with pain and redness. He was a known hypertensive and diabetic on medication. There was no history of trauma, joint pain, rashes, skin lesions, cough, fever, weight loss, or any immunosuppression of any kind. So on investigating, patient's liver function test, uric acid and lipid profile were deranged. And along with that, toxo-IgG and toxo-avidity were highly positive. However, toxo-IgM was negative. Patient had already received 3 doses of intravenous methylprednisolone and was on tablet Bactrim DS. So the best corrected visual acuity for distance in the right eye was 618, and for the near it was N6 with an add of plus 1.75. For the left eye, it was 66 N6. External examination was unremarkable, and in the slit lamp examination, anterior segment was also unremarkable, except in the right eye, there were granulomatous keratic precipitates in the Als triangle. So on the posterior segment evaluation, the media was hazy owing to the vitritis. The disc had edema and hyperemia, and we can see that there was sheathing present in almost all the vessels mostly in the nasal quadrant. Apart from that, there were confluent areas of necrotic retinitis present in the periphery. This is an OCT from the same date. So a diagnosis of right eye acute retinal necrosis with vitritis was made, and patient was offered intravenous acyclovir, slow infusion with 7 days with regular LFT and creatinine monitoring, and oral steroids that were to be initiated under the antiviral cover. Also, 3 doses of intravitreal ganciclovir were planned to be given weekly. Post the first dose of intravitreal ganciclovir, we can see that the patches of retinitis have started shrinking here, along with the disc edema, disc hyperemia, and sheathing. So intravenous acyclovir TDS was continued for 5 days with oral steroids, and this was to be followed with oral acyclovir now and oral steroids. Post the second dose of intravitreal ganciclovir, we can see that the patches have shrunk significantly along with vasculitis and the disc edema. So tablet valcyclovir was continued with tapering of oral steroids. In this visit, liver enzymes were raised, so isocol was added. This is the fundus picture post the third dose of intravitreal ganciclovir, and we can see that the patch of retinitis has now shrunk to this focal patch, and the sheathing and disc edema have markedly resolved. So tablet valcyclovir TDS and oral steroids were continued and eventually tapered, and patient was kept on a 1-monthly follow-up. 1 month post third intravitreal ganciclovir, patient's retinitis had resolved along with the vasculitis and the disc edema, and the tablet valsivir and oral steroids were tapered and stopped over subsequent visits. So patient was kept on regular follow-up, and in subsequent visit, patient complained of floaters and blurring of vision in his right eye. And on examination, although the retinitis had resolved, but there was presence of vitreous floaters and PVD. So patient was given an option of therapeutic vision clearing vitrectomy for better vision, which he underwent eventually. And he was kept on regular follow-up post the surgery. This is the last recorded visit of the patient. Here, here his retina was stable, and we can see the retinitis has resolved along with the signs of active vasculitis. In the last visit, the best corrected visual acuity in the right eye was recorded to be 6.9 for distance and 6 for near. So the take-home message, this is an OCT from the last visit where we can see there is some EZ disruption and distortion of foveal contour. So the take-home message from this case would be that acute retinal necrosis is an ophthalmic emergency, and we have to start systemic antivirals immediately on suspicion. These can be escalated to local intravitreal antivirals. Never to give steroids without antiviral cover. Always to expect and plan for complications, and monitor for toxicity and tailor antiviral doses. And since it can be bilateral, we have to always be alert for the involvement of the fellow eye. Thank you.
Can we have the comments from the presiding judge, Dr. Ashish Markan, sir, for his comments?
Thank you, Dr. Akanksha. What was the title of your presentation?
So it was ARN like time waits for none, since it's an ocular emergency, which progresses very quickly.
Fine. So why did you specifically highlighted the point of toxoplasma serology?
So because the patient was treated elsewhere, and there he had IgG positivity. For that, he was started on intravenous methylprednisolone and was also on the tablet bactrim.
I think the case has been beautifully managed. Just two comments from my side. The first thing is that the diagnosis of ARN is always clinical. We have seen in our clinics also sometimes patients do get toxoserology and they have been started on anti-toxo therapy. Even the diagnosis of toxo is clinical, diagnosis of viral retinitis is also clinical. Second thing is, why did in your case I think you hit very hard with the antivirals. Initially you started with intravenous, then you gave intravitreals also, then you gave Valsivir also. So I think, do you think adding intravitreal ganciclovir had any role in your case? Secondly, shifting from IV then to Valsivir had any role in your case? Was that actually required, or something else which could have been done in a different way?
Sir, in our case, the optic nerve was also involved. So to prevent optic neuropathy from developing, we added
No, I think adding intravitreal ganciclovir has no role in preventing the optic atrophy. That is the natural course of the disease. We do see optic atrophy being set in most of these cases as the disease heals. Secondly, so either you admit these patients, you start an IV Asivir, or you can actually directly on OPD basis can treat them on Valsivir. Both of them have an equal efficacy. The only thing is that you have to monitor the KFT of these patients because these are actually nephrotoxic drugs. That is the only point. But nowadays we usually do not admit these patients. We can actually manage them conservatively with tablet Valsivir, and it works really well. Yeah, and you must add oral steroids if you feel the vitritis is not improving. But then again, that is also not a must that every case oral steroids have to be added. But yeah, if the vitritis is not improving, when you add the oral steroids, the vision of these patients tends to improve as the vitritis goes down. Thank you so much.
Thank you, sir.
Thank you, Ashish sir. Again, from a comment from our expert panel, Dr. Mohammad Azam. Sir, your comments, sir, please.
Yes, thank you. This is actually a very interesting, very good presentation. But how did you think that IV methylprednisolone has a help actually in this type of patients? And the question is actually, should we started immediately or not with the antibacterial treatment or not?
So when the patient presented to the OPD, he had already received intravenous methylprednisolone elsewhere, and I think going to the toxo IgG positivity, he was started on this.
Would there be any negative impact with high dose of IV methylprednisolone?
So yes, sir, if the patient has ARN, it would be negatively impacted, and it would progress significantly with intravenous methylprednisolone. So we have to start the steroids under antiviral cover.
Okay, thank you. Good presentation.
Thank you, sir.
Thank you, doctor. You can come out of your slides. Stop slide sharing. Next, we have Dr. Neil Kavedia on Oguchi disease. You can present. Nice presentation, doctor. Great job.
Yes, I'll just share my slides.
Yeah, Dr. Neil. See you again for second time.
It's a pleasure, sir, to be a part of this. yet again.
Great job, doctor. Please, we want this enthusiasm. Please go ahead.
Are my slides visible?
Yes.
Slides are visible, doctor. Yeah.
Finish, can you take on the timer, please?
Yeah. When he starts, you can start.
Hello, everyone. Let us all today discuss a case of Oguchi disease, which I would like to call the flickering fundus. So, the 16-year-old girl was referred with chief complaints of decrease in vision at night since childhood. There was no history of any systemic illness. She consumed a normal diet, and her father had similar complaints of night blindness. The visual acuity was preserved to be 6.6. The anterior segment, intraocular pressure, contrast sensitivity, and color vision were within normal limits. On examining the fundus, the media was clear. Optic disc was normal with the CDR of 0.3. The retinal vessels were normal, and macular FR was plus. The posterior pole showed a golden yellow metallic sheen. The mid-periphery showed a normal fundus glow, which on exposure to light turned into a golden yellow metallic sheen suggestive of the Mizuho-Nakamura phenomenon. So now what exactly is happening here? This is the normal red glow of the fundus, and which we see on exposure to light how beautifully is converted into a golden yellow metallic sheen. Now, these are just normal fundus photographs, but the phenomena is dynamic. So let us take a step forward and do a mobile fundus videography for a patient. So this is the golden yellow metallic sheen in the posterior pole. We proceed by examining the quadrants. I would like your attention over here, where we'll see that how this red glow will now turn into a golden yellow metallic sheen on exposure to light. So this change in reflectivity, which we can see from red to golden, is because of a mutation in a rhodopsin gene. We'll have a slide later on in the presentation. So similar finding was present in all the 4 quadrants. So this is the red glow of the fundus, what we started with, and this is the golden glow, which we have after exposure to light. To confirm, we did an ERG in which we have reduced photopic responses and normal photopic responses because the cones are normal, and a negative positive dark adapted ERG. Now, if this would have been like a retinal degenerative condition like retinitis pigmentosa, we would only get a negative ERG. But this negative positive ERG is something which is typical of Oguchi disease. The OCT and fields were within normal limits and genetic testing was advised. With this, my diagnosis is Oguchi disease. So what exactly is happening here? In one word, the gene coding rhodopsin or arrestin is defective. As it goes by the name, arrestin binds to rhodopsin and it allows to reset it for the next light stimulus. Now, since there is a defect, this reset is disturbed and hence it will take hours to reset, leading to transient night blindness, and this is clinically seen in Mizuho-Nakamura phenomenon. There are 3 differential diagnoses. First is early retinitis pigmentosa, in which we can see the typical triad. Then fundus albipunctatus, in which we can see white flakes in the mid-periphery. And congenital stationary night blindness, in which the difference is the fundus will be normal, but there will be no improvement on prolonged dark adaptation. So why am I speaking about this case today? This case has been presented for its utmost rarity of less than barely 500 cases worldwide. Secondly, it is a type of congenital stationary night blindness, which means the patient's vision is not going to deteriorate over time. And thus it is important for the patient to know that its prognosis is going to be decently fair. And the patient shouldn't be anxious, confusing it with other retinal degenerative disorders, in which the vision will decrease over time, and for us also before issuing any disability certificate. One important point is a rare case reported in 2023 showed the progression of Oguchi to retinitis pigmentosa, and thus close follow-up for our case is also important to look at the progression. There is no curative treatment at present. One brownie point is a photo stress test, in which we can see that there is a prolonged before the start of the rod phase as compared to a normal straight line in normal patients, normal people. So this is my take-home message: negative ERG, golden yellow metallic sheen, and the DDs of Oguchi's. Now, before I end my presentation today, the only reason I could explain the Mizuho-Nakamura phenomena is because of the mobile fundus videography, and thus I would like to say that our smartphones do much more better than WhatsApp and Instagram. Thank you.
Great presentation as yesterday, doctor. Amazing. Good. Frugal use of smartphone photography also. Excellent job. We can move over to the judges. The presiding judge for this session would be Dr. Nawashi Sheikh. Madam, your comments on this, please.
So Dr. Neil, could you just give me some other differentials for Mizuho-Nakamura phenomena? In what other conditions could you possibly get this?
Yes, ma'am. Ma'am, in cases of severe retinitis pigmentosa, like very late stages, advanced stages, we could get it, ma'am. In retinoschisis, ma'am, we could get Mizuho-Nakamura phenomena. And it's in one of the case reports, they even speak about reverse Mizuho-Nakamura phenomena, ma'am, in which is seen in cases of carriers of retinitis pigmentosa.
Okay. Great presentation.
Thank you.
Can we have our some comments from our expert panel, Dr. Mohammad Azam?
Hello.
Mohammed sir, you
Hello.
can ask your yes, sir, please.
Yes, I actually think this is a very fantastic presentation, and how you have demonstrated the difference is very, very good. And this is very, very rare cases. And I think the most important thing what you have said is like the patient counseling and making sure the patient and the patient party understands of the condition. Good job. Thank you.
Thank you, sir.
Really, thank you very much, Dr. Neil. For the final presentation, we have Dr. Nishal Gimre from Nepal. Is Dr. Nishal on the floor?
Yes, sir, I'm here.
Oh, great. Amazing, doctor. We're really awaiting your presence. Doctor, you can share your slides, and the presiding judge for this session would be Dr. Shreyas Temkar, sir.
Yeah, maybe the earlier presenters presentation is still there, so I cannot share it.
Okay, Dr. Neil.
Neil, can you please unshare? Yeah. Go ahead, doctor.
So shall I start?
Yeah, please.
Respected judges and panelists, I'm Dr. Nishal Gimire from Nepal, and today my presentation is on a diagnostic and therapeutic dilemma, that is uveitis. So no financial disclosure and no conflict of interest. So we had a 28-year-old gentleman presented with gradual onset of redness of left eye associated with pain and blurring of vision and whitish discoloration on the black part of the same eye. Patient, however, denied any discharge or trauma to the eye. And patient had a similar history in the past for which he received treatment at Malaysia and was treated completely. After 3 months of stopping of medication, the symptoms again appeared and the progression was more rapid this time. Patient was under oral steroid, topical steroid, and cycloplegic and mydriatic, and also antibiotic drop. His systemic examinations were normal. On ocular examination, left eye visual acuity was 6 by 18. Intraocular pressure was 12 millimeter of mercury. Circumciliary congestion was present. There was a non-necrotizing scleral nodule, which was seen at 2 o'clock position, 2 millimeter away from the limbus. There was a global mass which was seen on the iris. There was presence of fine KPs and AC cells 4 plus according to sun grading. And hypopine of 0.1 millimeter was present. Posterior synechia was present from 6 o'clock to 10 o'clock. And this was the initial picture where we can see the mass and scleral nodule. And posterior segment examination was normal for the patient. And the lab investigation that we sent for infective pathology, we didn't get any positive report. The serology was negative. TPHA, VRL, they were negative. Calcium was also within normal limit. And chest X-ray was also normal. So here's how we proceeded. We made a provisional diagnosis. That was left eye recurrent anterior granulomatous uveitis. As the inflammation was not in control with oral or topical steroid, we suspected a fungal cause, and anterior chamber paracentesis was done, and aqueous was sent for a gram stain, KOH, and culture. Manto test was also sent, and intracameral voriconazole was given there. Reassurance to the patient and patient party was done, and we then stopped oral steroid. We started both oral and topical antifungal, that is fluconazole and natamycin, along with a cycloplegic and broad spectrum antibiotic. Blood and urine culture showed no growth. Aqueous culture showed no growth, and Manto test was 24 millimeter of induration after 72 hours, as we can see here. And on the 4th day after starting antifungal, patient was symptomatically better. The global mass was flattening, and the congestion was decreasing. Hypopine was also decreasing, and we continued the same treatment. On the 7th day of treatment and the antifungal treatment, the vascularized iris contour was pushed towards the pupil, and the scleral nodule was also decreasing, and there was no tenderness. Hypopine was decreasing, and AC inflammation was also decreasing. And we continued the same treatment, and then in the 14th day post-op follow-up, we saw the scleral nodule decreasing, and the visual acuity was 612. Congestion was decreasing. Posterior synechia was also decreasing. ACCL was only 10 to 12 per high power field. Single medium-sized KP was seen, and mass was completely gone, except for a yellowish deposit on the iris. And we continued the same treatment, and we added more topical steroid, that is 3-hourly prednisolone acetonide. And on 1 month follow-up, the base corrected visual acuity was 6/6 and ACCL was 5 to 6, and the iris mass was gone, and there was no scleral nodule as well. So concluding remarks, fungus not always causes pan-uveitis, might also cause isolated anterior uveitis. So non-improving uveitis with steroids, maybe we can suspect fungal cause. And I would like to credit my faculty members, Dr. Anu Manandar ma'am, Dr. Smita ma'am, and my colleague, Dr. Sudip Lal Rajbandari for managing the case. Thank you.
Thank you. Thank you very much, Doctor. Great presentation. Can we have comments from our esteemed judge, Dr. Shreyas sir, to give his final comments for the day and for this case?
Dr. Neil, it was a very well documented case, and fortunately, the management was also well done. So I have a few questions here. Like you just did the aqueous tap for this patient.
Yes, sir.
I would suggest, wouldn't biopsy of the particular lesion would have yielded you whatever the desired fungal element, like because everything grew negative.
Yes, sir. But we were where we work, it's a eye hospital, so biopsy is not easily available there, and also patient were
No, not
not.
biopsy.
Yeah.
Just with you, just go with intravitreal scissors and
Yes.
just cut that part of the iris and just take out that biopsy and send it for both pathology as well as microbiological examination. So
Yeah.
that would have yielded
Yes.
better microbiological load.
Yes, sir. That would have been better, sir. Yes,
Yeah,
definitely.
because I think even you had a scleral component there. So
Yes, sir.
because I think it had extended both into the anterior chamber as well as the sclera. So external samples would also have been tried in this patient.
Yes, sir.
Otherwise, well managed. Excellent.
Thank
you. I think Dr. Nishchal is the last case for the day, and we can call it a day. Thank you for all the participants and judges. Now over to the team lead, Dr. Prasanna, to give the ending comments for this day.
Thank you, Pranesh. I'm just trying to share my screen here. Just bear with me for a moment.
Okay. In the meanwhile, I thank the judges, Shreyas sir, my senior, Ashish sir, my senior, and Dr. Navashis, my colleague, everyone who were patiently evaluating all the 30 abstract at the stretch for 3 hours. It's a lot of dedication. Thank you so much for judging this, and I thank the panelists, Dr. Anujit, and our international panel, Dr. Muhammad Hassan, and Dr. Ishacharya, everyone for patiently discussing the cases. Thank you.
I think I must thank you personally, Dr. Karthikeyan. I think thank you for including us into this excellent program. Not only because we judged the program, but because we also learned so much from all these cases. Most of these cases were very unique, rare cases. We hardly see them in clinics. Don't see them very often. Some of these cases were actually very insightful. Thank you so much. Thank you to the entire YOSI team for including us and for conducting such a beautiful session.
Thank you, Dr. Ashish. Thank you, Karthi. So we have this certificate distribution which we very fondly carry out from Team Naadi. And in season 1, we had around 25 plus participation, and season 2, we had 30 plus participation. And in season 3, this was started as a brainchild of Dr. Karthikeyan Mahalingam, and the idea was, when we all 4 of us came together, was to take it globally this year, and we can see 15 countries part of it. And so here we are for the certificate distribution and the culmination of day 2, and it is not the last; it's just the penultimate day. So we would like to thank Dr. Shreyas for taking his time and patiently being a judge. Thank you, Dr. Shreyas. If you can say a few words, it's perfect. You are there.
I think we have already spoken a lot.
Yeah.
Thanks a lot for the opportunity. We learned a lot.
Thank you, Dr. Shreyas. Thank you, Dr. Ashish. Despite your fever, being here for us means a lot for Team Naadi and Team YOSI. Thank you for being here. A good friend of all of us. Thank you, Ashish.
Thank you so much, Prasanna. Thank you.
Thank you, Ashish. And thank you, Dr. Nawazish Sheikh, for all the discussion, for all the comments, and even Akuma person. I feel I too learned a lot. Thank you, Dr. Nawazis. Thank you,
so
Dr.
much for having.
Thank you, Dr. Nawazis. A few words you want to add, Doctor? Okay. So we move on to again, Pranesh has been a marathon moderator for us last 2 days. He has been a pillar and a backbone when it comes to Excel, when it comes to all technical modifications of the order and communication. He has been the real light along with Dr. Naranjan Karthik, who has again been a lot of grinding in the background work along with Karthikeyan Mahalingam. And unfortunately, Samir has not been able to join with us today. And we also have Dr. Anujit Paul. A few words from you, Dr. Anujit.
No, thank you. Thank you so much, sir, for having us. All the presentations were excellent. I would just one last word of encouragement. Would just like to encourage all the participants to consider publishing these cases, whether as images or as case reports or as case series. Some of them had excellent images as well. So a lot of things can be done in that regard. And Prasanna sir is always there to guide with the entire TNOA as well as the All India team. So that's just one small word which I thought that needs to be put right at the end.
Thank you, Anujit. And thank you, Azam sir, for your commitment. He had a very early day, started to Trichy and back to Madurai, and being here for YOSI, sir. Thank you for being there for us always for YOSI team.
Thank you, Dr. Prasanna, for having me and for entertaining me. And I think this is a very good opportunity for all of us. As you said, that these are not typical cases you see every day. And this is being a very refreshing cases for us and challenging cases for all of us. And I think like Dr. Anujit said, you guys also should really consider publishing these cases because many people can learn from this. Like there are some cases which only 1 or 2 case reports have been published. So this would be a good opportunity for all of us. Thank you for having me.
Thank you, sir. Thank you, Dr. Isha. I think Isha is not with us now. And thanks to all the international presenters. That is what has made this event a truly international show. Actually, at season 3 at Naadi, be it Dr. Gulnoor from Azerbaijan, Dr. Anizak who joined us from Indonesia, and we had a good team from Malaysia. Dr. Nurul was there from Malaysia, Dr. Zaim was there, and Dr. Ariana. So we had a good team, and again, Dr. Shafiq from Pakistan. Thank you to our international contingent. We had Dr. Jed Tabanpura from Philippines, and many more. Handing it back over to again the moderators, Pranesh and Niranjan, for distributing the Indian contingent certificates and the Nepal certificates. Over to you, Pranesh.
Thank you, Prashna, for the kind shift over. This is to congratulate the participation of Dr. Arpita Gupta for her presentation on alopecia, Annie Abraham for floaters and heat force syndrome, Kirtana for multimodal imaging, Nishi Prasad on retinopathy, Neelam Kumari for ectopic phobia, Dr. Priyanka for VKH, Dr. Asma for nudes, Dr. Chanvi, the one for and Dr. Anjana for Pandora's box, Dr. Krunal for posterior chamber puzzle, Janani for looking through the glass, Dr. Roshita Gargan for CRAO, Dr. Utkarsh for AMPI, Dr. Kavya for Arekanut injury, Dr. Akanksha for ARN, Dr. Neil Kavadia for Oguchi disease, Dr. Nishchal for uveitis, a diagnostic and therapeutic dilemma. Great presentations, everyone. Thank you very much for your kind participation.
Close, requesting all to switch on the camera for a group photo. And also we would like to thank Team Numerotech for all the technical support that they have given to us for the last 7 hours, 3.5 hours today and 3.5 hours yesterday. Numerotech team, thanks a lot, ma'am, and a lot of background work that they have given. Manjula, ma'am, we can go off live.
Okay, doctor. 1 second, doctor.
We can go off live. So we have this mandatory
1 second, doctor.
Group photo with YOSI. where I would request all